This will be the pulmonary system of Pance Prep Pearls. So first we'll start off with lung volumes. First, tidal volume, TV. The volume of air moved into or out of the lungs during quiet breathing. Residual volume, RV, is the volume of air remaining in the lungs after maximal expiration. This residual volume functions to maintain the alveolar patency, especially during end expiration. So some air is always left in residual volume. For expiratory reserve volume, ERV, this is the volume of air that can be further exhaled at the end of normal expiration. Inspiratory reserve volume, IRV, this is the volume of air that can be further inhaled at the end of normal inspiration. For vital capacity, or VC, this is the maximum volume of air that can be exhaled following maximal inspiration, which is the inspiratory reserve volume plus the TV plus the ERV. The total lung capacity is the volume of the lungs at maximal inspiration, and this is the vital capacity plus the residual volume. The functional residual capacity, FRC, is the volume of gas in the lungs at normal tidal volume and end expiration, so that's the ERV plus the RV. This is the air in which gas exchange takes place. That's the functional residual capacity. So an increase in functional residual capacity is seen in disorders with hyperinflation due to loss of the elastic recoil, such as in emphysema, or also PEEP, positive end expiratory pressure. A decrease in functional residual capacity is seen in restrictive lung diseases. FEV1, forced expiratory volume in 1 second, is the volume of air that has been exhaled at the end of the first second of a forced expiration. Forced vital capacity, FVC, this is the measurement of volume of air that can be expelled from a maximally inflated lung with a patient breathing as hard and as fast as possible. So you can see here the different lung volumes depicted on a graph so you can get a sense of how much the lung is filling up with each one. Next we'll go to atypical breath sounds. So first, wheezing. Wheezing is a high-pitched, whistling, continuous musical sound, usually louder during expiration as compared to inspiration, produced by narrowing or obstructed airways, and it's seen in obstructive lung diseases, especially asthma or COPD, bronchiectasis, bronchiolitis, lung cancer as well, sleep apnea, CHF, GERD, anaphylaxis, etc. For rhonchi, this is a continuous rumbling or rattling, coarse, low-pitched sound, sounds like snoring, that may clear with cough or suctioning. Rhonchi are caused by an increase in secretions or obstruction in the bronchial airways. For crackles or rails, this is discontinuous, high-pitched sounds heard during inspiration, usually not cleared by a cough. So crackles are on inspiration and wheezing is on expiration primarily. But crackles are due to popping open of the collapsed alveoli in small airways from fluid, exudates, or a lack of aeration in them. This is seen with pneumonia especially, or atelectasis, bronchitis, bronchiectasis, and especially pulmonary edema and pulmonary fibrosis. Stridor is monomorphic sounds, usually loudest over the anterior chest due to narrowing of the larynx or anywhere over the trachea. So you see this in croup. Can be heard during inspiration, expiration, or throughout the respiratory cycle. Next we'll move to COPD, chronic obstructive pulmonary diseases. So COPD is a progressive, largely irreversible airflow obstruction due to loss of elastic recoil and increased airway resistance. COPD includes emphysema and chronic bronchitis. It's common over 55-year-old patients, and chronic bronchitis is usually episodic, whereas emphysema has a steady decline over the years. Both usually coexist, with one being more dominant, however. Risk factors, of course, cigarette smoking and exposure, 90%, and only 15%, however, will develop COPD. There's also genetic causes like alpha-1 antitrypsin deficiency, which is only a genetic cause linked to COPD in younger patients under 40. So there's also, again, occupational or environmental exposures, but you should know if they're younger, alpha-1 antitrypsin, and if they're older, COPD. So first for emphysema, this is permanent enlargement of the terminal air spaces due to terminal bronchioles with no obvious fibrosis. Etiology, smoking is the most common. And pathophys is chronic inflammation and decreased protective enzymes like alpha-1 antitrypsin and increased damaging enzymes like elastase release from macrophages and neutrophils. So it destroys the elastic recoil of the lung. This causes alveolar capillary destruction and alveolar wall destruction. It has a matched VQ defect and a decreased gas exchange surface area, the DLCO. Loss of elastic recoil and airway obstruction makes expiration an active process, and increased compliance leads to airway obstruction, increased air trapping. So the problem with this emphysema is that they can't get the air out. And remember, that's a matched VQ defect. Emphysema is typically central-lobular, proximal acinar involvement, most commonly seen with smoking. So as the smoke comes in, it's going to hit the proximal areas of the lung first, causing more damage there. If it is pan-acinar or diffuse, it's associated with alpha-1 antitrypsin. And remember, this might be in younger patients as well. It could be paraseptal as well, distal acinar. Can be seen with the above two or with spontaneous pneumothorax if it's isolated. Clinical manifestations of emphysema are dyspnea, which is hallmark, as well as chronic cough with or without sputum, mostly dyspnea though. Physical exam, hyperinflation, decreased breath sounds, increased anterior posterior diameter, AP diameter, which is a barrel chest deformity, due to the body's wanting to increase the lung capacity to increase oxygen uptake. Hyperresonance to percussion, wheezing, and they might be cachectic and non-cyanotic. They're also called pink puffers in emphysema. For severe disease, you want to see pursed lip expiration, increased airway pressure to prevent alveolar collapse, and semi-tripod positioning, sitting forward to improve breathing. So we see the tripod positioning also with epiglottitis, but got to keep emphysema on there too. Diagnosis, pulmonary function tests, gold standard. Obstructive pattern that is not fully reversible. Airway obstruction, decreased FEV1 to FVC ratio under 70% predicted, and a decreased FVC. Hyperinflation will have increased volumes as well on all of them, and a decreased DLCO in emphysema. So that's that diffusion capacity across the alveoli. For chest radiographs, hyperinflation, flattened diaphragms, increased AP diameter, the barrel chest, and decreased vascular markings and bulla are also possible, importantly, as emphysema can lead to spontaneous pneumothoraxes. Chronic bronchitis, next. This is defined as productive cough for at least 3 months a year or 2 consecutive years. The etiologies, again, are smoking, most common, also some pollution and dust. Pathophys is chronic inflammation leading to mucus gland hyperplasia, goblet cell mucus production, dysfunctional cilia, importantly, and infiltration of neutrophils and CD8 plus cells. So the dysfunctional cilia, the smoking like stuns the cilia, so it can't move mucus, it can't ascend mucus up anymore. So it just gets stuck in there, it can get infected. Three cardinal symptoms for clinical manifestations of chronic bronchitis are chronic cough, sputum production, and dyspnea. They may have prolonged expiration as well. On physical exam, they'll have crackles, rales, rhonchi, and wheezing. Signs of cor pulmonale include an enlarged tender liver, JVD, and peripheral edema. Cyanosis and obesity, blue bloaters. So importantly, you have in chronic bronchitis some right heart strain and some backup into the systemic venous circulation, which is why you see that enlarged liver, the JVD, and peripheral edema. Diagnosis, pulmonary functional tests are gold standard, an obstructive pattern that is not fully reversible. You'll have airway obstruction with a decreased FEV1 to FVC ratio under 70%, again predicted, and a decreased functional vital capacity as well, FVC. Hyperinflation can be seen with increases in all lung volumes, but a normal DLCO, unlike emphysema. Chest radiograph for chronic bronchitis, pulmonary hypertension, again the enlarged right heart border, increased AP diameter and vascular markings. An EKG will see cor pulmonale, again the right ventricular hypertrophy, right atrial enlargement, and right axis deviation. So axis deviation, as that right heart enlarges, it shifts the heart slightly to the right. So you'll see the axis deviation on the EKG. You may also see MAT, multifocal atrial tachycardia, which is common with chronic bronchitis especially. CBC, increased hemoglobin and hematocrit due to the chronic hypoxia, so more erythropoiesis. The kidneys stimulate more erythropoiesis from the long-term hypoxia. And on ABG, a respiratory acidosis, because they're severely hypoxic and hypercapnic. So next, just to summarize the differences between emphysema and chronic bronchitis. So for clinical manifestations of emphysema, you have dyspnea, accessory muscle use, and maybe a mild cough and that pursed lip breathing. As opposed to chronic bronchitis, you do have the productive cough as the hallmark, and its prolonged expiration as well. For physical exam, emphysema is more hyperinflation and hyperresonance to percussion, with decreased or absent breath sounds, decreased fremitus, and a barrel chest. As opposed to chronic bronchitis, you hear a lot of crackles, rhonchi, and wheezing, and changes in location with the cough. And you also see signs of cor pulmonale, which are peripheral edema again and cyanosis. On ABG, emphysema will have respiratory acidosis if severe, and chronic bronchitis will definitely have a respiratory acidosis, and also erythropoiesis. We'll see an increased hematocrit and RBCs. For VQ mismatch on emphysema, it's matched, and it's a severe VQ mismatch on chronic bronchitis, so that's a difference there. And also very hypercapnic in chronic bronchitis, again leading to that acidosis. And the appearance is classically for emphysema pink puffers, which are cachectic, pursed lip breathing, and non-cyanotic, and blue bloaters, obese and cyanotic. So what is the management of COPD? So factors that reduce mortality in COPD are smoking cessation is the most important step in the management of COPD. They have immediate effects. Oxygen therapy for those with a PaO2 under 55 or an O2 saturation under 88. Mortality benefit is directly proportional to the number of hours that oxygen is used. For pneumococcal vaccinations and annual influenza vaccinations, both should get them. General management, exercise, pulmonary rehab, regular review of correct inhaler technique, and also antibiotics for acute exacerbations, especially in chronic bronchitis with all that mucus. You can use macrolides like azithromycin, chlorith, as well as cephalosporins like cefuroxime and cefixime, augmentin, and fluoroquinolones. So for the management of COPD, you use the GOLD criteria, and it looks at the FEV1 and FEV1 to FVC ratio. Minimally symptomatic with low risk of exacerbation is category A. You want to do a SABA and a SAMA first. More symptomatic with low risk of exacerbation, you can again do the SABA and SAMA, or you can add a LAMA, which is like formoterol, salmeterol. Or the LAMA is tiotropium. Minimally symptomatic on a day-to-day basis, you can use the LAMA, which is tiotropium. And in general, combination of LAMA plus a LABA is more efficacious than monotherapy. And as a monotherapy, LAMA is more efficacious than LABA. So oxygen therapy in COPD, the rationale is that patients develop pulmonary hypertension and subsequent right heart failure, cor pulmonale, as a result of hypoxic vasoconstriction, which increases the right-sided arterial pressure. So it's harder for the right heart to push against all that vasoconstriction in the lungs in order to oxygenate it properly. So the use of long-term oxygen reduces mortality and improves quality of life in severe COPD. Indications for O2 are an O2 sat under 88%, signs of cor pulmonale, or a PaO2 under 55 millimeters of mercury. There's also something called lung reduction surgery. This improves dyspnea by removing the damaged lung, which allows the remaining lung to expand fully and function more efficiently. A lung transplant can be done, especially for patients with alpha-1 antitrypsin deficiency. So to go over some of the medications, first will be bronchodilators. These improve symptoms but do not decrease the progression and reduce mortality. LAMAs, which are tiotropium, which are an inhaled powder. These are long-acting anticholinergic or antimuscarinic that leads to bronchodilation, and this is M1 and M3 selectivity. The benefits are improves lung function, decreased hyperinflation, improves quality of life, and a monotherapy might be slightly more efficacious than LABAs. Adverse effects, of course, are anticholinergic with the dry mouth, thirst, blurred vision, urinary retention, and difficulty swallowing. SAMAs next are ipratropium. The mechanism is short-acting anticholinergic, antimuscarinic, that leads to bronchodilation, again, M1, M2, and M3 receptors. Indications are as needed for relief of intermittent increases in dyspnea, may be combined with a short-acting beta agonist. Again, adverse effects, anticholinergic with the dry mouth, thirst, all the anti-sludge effects. LABA, salmeterol or formoterol, long-acting beta-2 agonist, decreases exacerbations, improves quality of life and function. But again, they do not reduce mortality. SABAs, like albuterol, short-acting beta-2 agonists, indications as needed for intermittent relief of dyspnea, may be combined with a SAMA. Remember, that's your go-to. Adverse reactions are beta-1 cross-reactivity, tachycardia, palpitations, tremors, CNS stimulation especially. And also inhaled glucocorticoids like fluticasone. Indications can be added to a LABA or a LAMA for severe or persistent disease. And again, adverse reactions are oral candidiasis, but these are not added first, so the inhaled corticosteroids are not a first-line addition. So next, moving to cystic fibrosis. Cystic fibrosis is an autosomal recessive exocrinopathy, most common in Caucasians and Northern Europeans. The pathophys is a mutation in the cystic fibrosis transmembrane conductase receptor, the CFTR, gene that leads to abnormal chloride and water transport across exocrine glands throughout the body, leading to a thick, viscous secretion of the lungs. Also the pancreas, sinuses, intestines, liver, and GU tract. So wherever there's secretions, makes them more viscous. Clinical manifestations: in infancy, you'll have the meconium ileus, failure to thrive, and diarrhea from malabsorption. Pulmonary, cystic fibrosis is the most common cause of bronchiectasis in the US. Also some malabsorption from fat-soluble vitamins like A, D, E, and K. Steatorrhea, diarrhea, recurrent pancreatitis due to its inability to secrete, distal intestinal obstruction, biliary cirrhosis, as well as sinusitis. For diagnosis of cystic fibrosis, the most important one is the elevated sweat chloride test, which is the test of choice and the most accurate test. So chloride levels 60 or greater on 2 occasions after a pilocarpine administration is diagnostic. And remember that pilocarpine is a cholinergic drug that induces sweating. For chest radiographs, you may see bronchiectasis and hyperinflation. PFTs will show an obstructive pattern, and again, usually irreversible. In DNA analysis, genotyping is not as accurate as the sweat chloride test because there are more types of mutations than those tested with genotyping. For management, antibiotics are often needed due to the stasis of the mucus. Macrolides, again, cephalosporins, cefuroxime, cefixime, augmentin, fluoroquinolones, and inhaled aminoglycosides like tobramycin. Airway clearance treatment: inhaled bronchodilators, decongestants, mucolytics, inhaled recombinant deoxyribonuclease, which breaks down large amounts of DNA and respiratory mucus that clogs up the airways. So that's N-acetylcysteine, NAC. Also the antidote for Tylenol overdose. Supportive is pancreatic enzyme supplementation of fat-soluble vitamins as well, like A, E, D, and K. And lung and pancreatic transplantation in select cases. So now we'll go over obstructive versus restrictive disorders. So for PFTs on obstructive, you'll have increased lung volumes. There'll be hyperinflation with increased total lung capacity, residual volume 2 total lung capacity, and functional residual capacity. Again, for obstruction, you'll have a decreased FEV1, a decreased FVC, and again, a decreased FEV1 to FVC ratio. And FEV1 decreases more than FVC. Compliance, increased compliance, and emphysema. Examples are asthma, COPD, bronchiectasis, cystic fibrosis. And also note that co-workers' pneumoconiosis often presents as an obstructive pattern, but the rest of the pneumoconioses are typically restrictive. Just co-workers is obstructive. And moving to restrictive, we have the decreased lung volumes, again with the decreased total lung capacity, residual volume 2 total lung capacity, functional residual capacity, and functional vital capacity. And for this one, however, it's a normal FEV1 to FVC ratio. They have no problem initiating getting that air out in the first 1 second, as opposed to obstructive, which does. So the compliance, however, is decreased in restrictive. And disorders such as restrictive disorders are sarcoidosis, pneumoconiosis, idiopathic pulmonary fibrosis, IPF, and also decreased muscular effort like myasthenia gravis or polio, scoliosis or mesothelioma. Next, moving into bronchiectasis, although we kind of went over it a little bit in cystic fibrosis, but bronchiectasis itself is permanent and irreversible dilatation of the bronchial airways. Again, cystic fibrosis is the most common cause at 50%, and they do have a lot of recurrent lung infections, especially with Pseudomonas. And Pseudomonas is the most common bug found, especially if due to cystic fibrosis. H. influenza is the most common cause if not due to cystic fibrosis, such as those seen in COPD. Airway foreign bodies, alpha-1 antitrypsin deficiency, collagen vascular disease like rheumatoid, aspergillosis, and immune deficiency. Pathophysiology, again, dilatation of the airways and impairment of the mucociliary escalator leads to repeat infections, airway obstruction, and parabronchial fibrosis. Increased risk for Pseudomonas, MAC, Mycobacterium avium complex, and Aspergillus. Clinical manifestations are persistent productive cough with thick sputum, dyspnea, and pleuritic chest pain, and hemoptysis, importantly, bronchial artery erosion. This will lead to. Physical exam, nonspecific with some crackles, wheezing, or rhonchi. And for diagnosis of bronchiectasis, you want to do a high-resolution CT scan, which is the preferred imaging of choice. So for findings, you'll see increased thickening of the bronchial walls, airway dilation, and lack of tapering of the airway. This is that classic tram track appearance for bronchiectasis. Also, you see the signet ring sign, which is increased airway diameter over the adjacent vessel diameter. For chest radiographs, abnormal but nonspecific. PFTs are the gold standard, however. Obstructive pattern that is not fully reversible. And you'll see airway obstruction with the decreased FEV1, and again the decreased FEV1 to FVC ratio under 70 since it is obstructive. And you also see hyperinflation with increasing all the volumes. For management, it's conservative to start with chest physiotherapy, which helps you hit on the chest and it helps clear out that mucus. Also the mucolytics like NAC and bronchodilators. Also antibiotics, again, often needed, macrolides, cephalosporins, cefuroxime and cefixime, augmentin, fluoroquinolones, inhaled aminoglycosides like tobramycin. And you might want to do antibiotic cycling, so 1 weekly for each month. Surgery, resection, or transplantation in severe or refractory cases. So again, for findings on X-ray and CT, remember CT is very good for bronchiectasis. You'll see the signet ring sign as well as the tram track appearance. Next will be asthma. This is a reversible, often intermittent obstruction of the small airways. The pathophys has 3 components. One is airway hyperreactivity, bronchoconstriction, and then inflammation. It's increased IgE, which binds to mast cells, initiating an inflammatory response and including increased leukotrienes. Can present at any age, but often the initial occurrence is most common in children. The risk factors are atopic. Atopy is the strongest risk factor with a family history, air pollution, obesity, also environmental tobacco smoke, and a male gender. You must know the Samter's triad, which is aspirin exacerbated respiratory disease, consists of asthma, chronic rhinosinusitis with nasal polyps, and sensitivity to aspirin or NSAIDs. So how I remember it is Samter's begins with SA, and all the things in Samter's triad have AS, so nasal polyps, aspirin, and asthma. Also the atopic triad, which is patients with one condition are more likely to develop one or two of the other, asthma, atopic dermatitis like eczema, or allergic rhinitis. For triggers, there's intrinsic and extrinsic. For intrinsic, there's non-allergic, like anxiety, stress, exercise, cold air, hyperventilation, or viral infections. And extrinsic or allergic, like animal dander, pollen, mold, dust. And this extrinsic or allergic is associated with IgE. Others are like aspirin, NSAIDs, beta blockers, histamine, and GERD. Clinical manifestations, the classic triad of dyspnea, wheezing or cough, especially at night. May have chest tightness and fatigue. Clues into severity include intubations, hospital admissions, or ICU admissions previously. On physical exam, prolonged expiration with wheezing. They'll have hyperresonance to percussion, decreased breath sounds, tachycardia, tachypnea, and accessory muscle use potentially. Also know severe asthma and status asthmaticus, inability to speak in full sentences, also some tripod positioning, and very bad is silent chest, which is no air movement. Also altered mental status, which is an ominous finding, pulsus paradoxus, inspiratory blood pressure drop of over 10 millimeters of mercury, and the PEFR, peak expiratory flow rate, under 40% of the predicted. So findings of long-standing disease will be nasal polyps or atopic dermatitis. How do you diagnose this? With PFTs, the gold standard, reversible obstruction, which is a decreased FEV1, decreased FEV1 to FVC, and increased residual volume, total lung capacity, and residual volume to total lung capacity. You can do the broncho provocation test, which is the methylcholine challenge, and you should see 20% decrease in the FEV1, followed by the bronchodilator challenge, which you'll see an increase in FEV1 over 12%, which is expected and diagnostic. So the methylcholine is choline, which is parasympathetic, so it's going to close the airways a little bit, and you'll see a decrease in FEV1. And then if you then give a bronchodilator, you should see an increase right back up, and this is diagnostic. So diagnosis of acute exasthma exacerbation, peak expiratory flow rate you want to do. This is the best and most objective way to assess expiratory exacerbation severity and patient response to treatment. So to discharge a patient with asthma, you need to go to the discharge criteria, which is a peak expiratory flow rate over 70% predicted, or flow rate over 15% initial attempt. Subjective improvement as well. Pulse ox under 90 is indicative of distress. An ABG is usually not ordered, but you may see a respiratory alkalosis from the tachypnea. Chest radiograph is usually normal, generally not helpful in the diagnosis of asthma, but may be used to rule out other symptoms. So now for the different medications we use in asthma. The quick relief for acute exacerbation, or rescue drugs, the SAMA, of course, and SABAs. So short-acting beta agonists, SABAs, albuterol, levoalbuterol, terbutaline, and epinephrine. Indications are first line for an exacerbation. They're the most effective and the fastest. They work in 2 to 5 minutes. The mechanism is bronchodilator, especially peripherally, decreases the spasm, increases the risk, increases the ciliary movement, and decreases airway edema and resistance. The administration should be by a meter dose inhaler or a neb, and nebulizers are the most common in the ED especially. Beta 1. For side effects, beta 1 cross-reaction, you'll have tachycardia and arrhythmias, muscle tremors, CNS stimulation, and hypokalemia. So remember, we actually can give a SABA and hyper-K to force potassium into the cell, which leads to hypo-K. So we can see that hypo-K would be a side effect of SABAs. Anticholinergics next, also called antimuscarinics. Ipratropium. These are central bronchodilators, inhibit the vagal mediated bronchoconstriction, and inhibits nasal mucosal secretions. And don't forget, there's positive synergy between the beta 2 agonists and anticholinergics, and they're most useful in the first hour. Side effects, you would expect some thirst, blurred vision, dry mouth, urinary retention, dysphagia, acute glaucoma, and BPH, all those anti-sludge effects, and corticosteroids also, prednisone, methylprednisolone, and prednisone. Mechanism of action, anti-inflammatory. All but the mildest exacerbations should be discharged on a short course of oral steroids, not inhaled, 3 to 5 days unless contraindicated. Steroids decrease relapse and reverse the late pathophysiology. Short courses don't need tapering unless chronic steroids or recent treatment with repeated courses of a short period. Side effects again are immunosuppression, catabolism, hyperglycemia, fluid retention, osteoporosis, and growth delays. For some long-term chronic control maintenance of asthma, you have the ICS, beclomethasone, flunisolide, triamcinolone, And the indications for these inhaled corticosteroids are first-line long-term for persistent and chronic maintenance. They have a low incidence of side effects, but one side effect notable is oral candidiasis, so you want to use a spacer and rinsing the mouth out after the inhaler is used to decrease the risk of this. You can do LABAs, long-acting beta agonists. That's beta-2 agonists, so they're not cardioselective. That's salmeterol, budesonide or formoterol, and fluticasone salmeterol are options. And those are ICS-LABA combos. But the mechanism for the LABA is bronchodilator. Again, indications, long-acting beta-2 agonist added to steroids, only if persistent asthma is not controlled with the ICS alone. So you always start the ICS first. Contraindications, not used as a rescue drug in acute exacerbations or as a monotherapy for long-term asthma. Also to note, mast cell modifiers like cromolyn and nitochromil. So prophylaxis for cold air or exercise. And the mechanism is inhibits mast cell and leukotriene-mediated degranulation. And again, used for prophylaxis only for mast cell modifiers. They're indicated to improve lung function, decrease reactivity, and it inhibits acute response to cold air, exercise, and sulfites. Minimal side effects. So the effective prophylaxis in this case takes several weeks as well. And we also have the leukotriene modifier receptor antagonists, the LTRAs. This is montelukast, zafirlukast. And the mechanism is blocks leukotriene-mediated neutrophil migration, capillary permeability, smooth muscle contraction, and leukotriene receptor inhibition. Indications used in asthmatics with allergic rhinitis and aspirin-induced asthma as well. Next, we'll make a note on theophylline as well. This is a methylxanthine, which is actually similar to caffeine. So theophylline is a bronchodilator that improves respiratory muscle endurance, PDE inhibitor, which inhibits leukotriene synthesis and inflammation. It's not used, often due to the narrow therapeutic index. Smoking decreases theophylline levels, so higher doses of theophylline are needed in smokers. It's indicated for long-term asthma prophylaxis in selected patients, and of course not used in asthma exacerbations. And adverse effects are very sympathetic, with nervousness, nausea and vomiting, anorexia, headache, CNS respiratory stimulation, diuresis and tachycardia, and also, of course, narrow therapeutic index. Toxicity may cause arrhythmias and seizures. So note for theophylline has a narrow therapeutic index. And there's also omalizumab, which is an anti-IgE antibody, which inhibits IgE inflammation. It's used in severe uncontrolled asthma. So now just to quickly go over the classification of asthma severity and how do we know what classification the patient falls under. So there's intermittent and there's persistent. Within persistent, there's mild, moderate, and severe. So for intermittent, the SABA use is under 2 days a week or under 2 times per week. The nighttime awakenings are under 2 times per month. And the FEV1 is over 80% predicted. For persistent mild persistent, the nighttime awakenings are 4 times or 3 to 4 times per month. And again, the FEV is still over 80% predicted. And you want to do the low dose ICS. For moderate persistent, over 1 times per week of nighttime awakening. So that's 8 per month, but not nightly. And for this, the FEV starts to drop at 60 to 80% predicted. And here you have the low ICS plus a LABA or increased ICS alone. For severe persistent, you have usually nighttime awakenings with FEV1 under 60% predicted, and you can add a high dose ICS plus LABA, and you may also add that anti-IgE, which is omalizumab. So how I remember this is they usually give the nighttime awakenings. So for intermittent, it's under 2 times, and I go by monthly, so under 2 times a month for nighttime awakenings for intermittent. And then mild persistent is under 4 times per month, moderate persistent is 8 times per month, and severe persistent is unlimited. So 2, 4, 8. So it just doubles, and that's how I remember it. So next we'll go to sarcoidosis. Sarcoidosis is an idiopathic, chronic multisystem inflammatory granulomatous disease. It's more common in females, African Americans, and Northern Europeans. Pathophys is exaggerated T cell response to a variety of antigens or self-antigens, leading to a central immune system activation, a granuloma formation, and peripheral immune depression. So most importantly, 50% are asymptomatic on clinical examination, and pulmonary you may find dry, non-productive cough and dyspnea, and rales. You'll have lymphadenopathy, importantly the intrathoracic lymphadenopathy, those classic hilar nodes on X-ray, those classic hilar nodes and paratracheal nodes as well. For skin, importantly, is erythema nodosum, and also lupus pernio, most specific. So erythema nodosum is classic, and lupus pernio is most specific. So this is on the face, the lupus pernio. It looks like SLE, and also maculopapular rash, which is most common. You may also see parotid gland enlargement. Eyes, some anterior uveitis, some cardiac findings, rheumatologic findings, neurologic findings like cranial nerve 7 palsies and diabetes insipidus. And also important to know Lofgren syndrome, which is the triad of erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgias with fever. So that's Lofgren syndrome for sarcoidosis. So remembering those bolded terms, erythema nodosum, lupus pernio, Lofgren syndrome, that triad of bilateral hilar lymphadenopathy, polyarthralgias with fever, and again, erythema nodosum. So for diagnosis, it's based on clinical and radiographical findings and in non-caseating granulomas, as opposed to TB, which is caseating, and excluding other causes. So for chest radiograph, this is the best initial test. You'll see that classic bilateral hilar lymphadenopathy, and it's interstitial lung disease. So you'll see the reticular opacities, ground glass appearance, maybe some eggshell calcifications, and fibrosis. So pulmonary functional test, you'll see a restrictive pattern, which is a normal or increased FEV1 to FVC, normal or decreased FVC, because you have less of a capacity of the lung in total, and a decreased FEV1. Decreased lung volumes overall, and PFTs are primarily used to monitor the response to treatment. You can also do a tissue biopsy in sarcoidosis, which you'll see a non-caseating granuloma, and this is the most common, this is the most accurate test rather. The best initial test is radiograph, the most accurate is biopsy. And for labs, importantly, you also see increased ACE levels, angiotensin converting enzyme. Also hypercalciuria, hypercalcemia, increased vitamin D. For management, asymptomatic, you can just observe them. For symptomatic, oral corticosteroids are first line, very importantly. And if refractory, methotrexate or hydroxychloroquine. Prognosis is good overall, 40% spontaneous resolve, 40% improve with treatment, 20% progress to irreversible lung injury. They'll have a good prognosis if they're just stage 1 with only erythema nodosum. So if they have the interstitial lung disease, which they develop, or they have the lupus pernio, they have a poor prognosis. Next, for idiopathic fibrosing interstitial pneumonia, pulmonary fibrosis. This is a progressive scarring of the lungs due to an unknown cause. Most common in men 40 years of age and smokers. Clinical manifestations are progressive dyspnea, non-productive cough, and on physical exam they'll have fine, dry, bibasilar inspiratory crackles, clubbing of the fingers as well may be seen from that chronic hypoxia. For diagnosis, chest radiographs, reticular opacities, and this is honeycombing classically. Chest CT is the preferred imaging modality, and again you see the reticular honeycombing, focal ground glass opacification. You may also see traction bronchiectasis or bronchiole ectasis. On PFTs, it's a restrictive pattern, which again, normal or increased FEV1 to FVC, so no trouble getting that first second of air out, and decreased lung volumes in total, and also a decreased DLCO, which we typically saw in emphysema, but it's also in this idiopathic interstitial pneumonia or fibrosis. So biopsy, we'll see honeycombing, and management, lung transplant is the only possible cure. However, it's important to know pirfenidone and nintedanib. These are antifibrotic agents that may slow progression but do not significantly benefit mortality. That's pirfenidone and nintedanib, but lung transplant is the only possible cure for this. Next will be the pneumoconioses and environmental lung diseases. So pneumoconioses is chronic fibrotic lung disease secondary to inhalation of a mineral dust. So first, silicosis. So I think silicone is like a rock. So you'll have the quarry work, the granite, slate, and quartz, pottery makers, and sandblasting. So typically with the pneumoconioses, it's going to matter where they work and where the lesion is in their lung. So if they work in the ground, then it will be in the apical area, and if they work somewhere higher up, then it will be in the base of the lung. So again, silicosis, quarry work, granite, slate, quartz, pottery makers, sandblasting, masonry, etc. They'll have chronic asymptomatic, often asymptomatic, but they may have chronic lung findings. For diagnosis, chest radiographs, there'll be multiple small round nodular opacities, primarily in the upper lobes. So if they're working in a quarry, that's low, so you're going to find them in the high apical lobes. For eggshell calcifications and hilar mediastinal nodes may be seen as well. For coal workers' pneumoconiosis, also known as black lung, this is the only pneumoconiosis that is an obstructive pattern, as opposed to restrictive. So it's important to know with this one, they'll have those lung findings as well as Kaplan syndrome, which is coal worker pneumoconiosis plus RA, rheumatoid arthritis, and this is serologic positive. So Kaplan is coal workers plus RA, rheumatoid arthritis. Chest radiograph will have small nodules in the upper lobes. Again, they work in the ground, so you're going to see the nodules in the upper lobes with hyperinflation of lower lobes in an obstructive pattern, so resembles emphysema. Again, obstructive pattern, and biopsy will show dark lung, the black lung, and management is supportive. Next, berylliosis. Berylliosis is typically found in aerospace and electronic type jobs. Diagnosis is chest radiograph, normal usually, but may have some higher lymphadenopathy. No specific findings for berylliosis to mention. Management is corticosteroids, and it's associated with increased risk of lung, stomach, and colon cancer. Byssinosis is lung disease due to cotton exposure in those employed in the textile industry. So this is classically known because the symptoms tend to get worse at the beginning of the work week and then improve later in the week or on the weekend. So it's known as Monday fever in byssinosis. And that's cotton exposure. So asbestosis, we have to know a little bit more. Asbestosis is a slow, progressive, diffuse pulmonary fibrosis as a result of inhalation of asbestos fibers. It's seen typically 15 to 20 years after a lengthy exposure to asbestos. And risk factors are destruction, repair or renovation of old buildings, and insulation, and fire-resistant products, shipbuilding, etc. And asbestos was commonly used due to its fire-resistant thermal and electric insulation attributes. Clinical manifestations, dyspnea, bibasilar crackles, importantly, on the lower lobes. So you use asbestos in the ceiling, you're going to have the bibasilar crackles in the lower lobes. So they're working up high, lower lobes. Chest radiograph, you'll see pleural plaques, which are pleural thickening or calcifications of the parietal pleura, especially involving the lower lobes. Interstitial fibrosis, honeycombing of the lung, and a shaggy heart sign, which is indistinct heart borders, ground glass appearance of the lung fields. So remember, this is something where it affects the pleura as well in asbestosis. PFTs will show again a restrictive pattern, normal or increased FEV1 to FVC, normal or decreased FVC, and a decreased lung volume. Biopsy may show linear asbestos bodies in the lung tissue. These are called ferruginous bodies. And management, no specific management, may do bronchodilators, O2, corticosteroids, lung transplant. In complications, importantly, bronchogenic carcinoma, which is most common, and malignant mesothelioma of the pleura, which is most specific. So very important. Pleural plaques, think malignant mesothelioma of the pleura. Next will be alpha-1 antitrypsin deficiency. This is a genetic disorder that leads to pan-acinar emphysema. So it's a deficiency in which the whole lung will be affected. Hepatomegaly and cirrhosis. Manifestations are emphysema, pan-acinar emphysema, hepatomegaly, signs of cirrhosis as well, due to alpha-1 antitrypsin being made in the liver, So you have those effects on the liver. And liver biopsy is a definitive, as you can also see the chest radiograph, CT scan, and PFTs. And the management is an IV pooled alpha-1 antitrypsin, and surgical is a lung transplant. Silo filler disease. This is a hypersensitivity pneumonitis from nitrogen dioxide gas exposure related from plant matter, stored in the silos as they ferment. And this is another type of pneumoconiosis, and you want to have farmer's lung on the differential. So where you typically find this is in combustion exposures and also occupational areas in which there's plant matter stored in the silos. Next will be parrot fever or piscatosis, infection with Chlamydophila piscati due to exposure to infected birds. Inhalation of organism or dried feces, flu-like symptoms, and tetracyclines are first line. So the infection is actually a chlamydia infection, so it would make sense that tetracyclines would be first line for piscatosis or parrot fever. Next we'll move into influenza. Influenza A is associated with more severe outbreaks compared to B, and it primarily via transmission airborne respiratory secretions like sneezing, coughing, talking, and breathing. And those that are at increased risk are over age 65, pregnant, and immunocompromised. Children are an important vector for the disease, as the highest rates of infections are seen among children, but individuals 65 or older are at a highest risk for complications, so kids giving it to their grandparents. Complications include pneumonia, respiratory failure, death, meningitis, myocarditis, encephalitis, etc. Clinical manifestations of the influenza are abrupt onset of a wide variety of symptoms, including headache, fever, chills, malaise, URI symptoms, pharyngitis, and pneumonia. Myalgias are most commonly involving the legs and lumbosacral areas. You want to do a rapid nasal flu swab or viral culture. And for management, supportive is the mainstay in healthy patients, such as acetaminophen or salicylates and rest. But antivirals are recommended in patients that are hospitalized or at a high risk for complications, such as those who are 65 and older, with cardiovascular disease, except isolated hypertension, pulmonary disease, immunosuppression like diabetes, malignancy, HIV, post-transplant, chronic liver disease, and hemoglobinopathies like sickle cell or thalassemia. And what you can use for these antivirals are neuraminidase inhibitors like oseltamivir, and this is best used if initiated within 48 hours of the symptom onset, so under 2 days. So it works against both influenza A and B. And adverse effects of oseltamivir are skin reactions, nausea, vomiting, transient neuropsychiatric events as well. You can also do adamantine derivatives. Adamantine and rimantadine are effective against influenza A as well. Chemoprophylaxis. So oseltamivir can be used in high-risk groups 1 year or older in cases of outbreaks and exposure. During influenza outbreaks in long-term care facilities, all residents should receive chemoprophylaxis regardless of immunization status. So that's important. For the general population, only individuals who did not receive the annual influenza vaccine should be given chemoprophylaxis. So to go over a little bit more about the influenza vaccine itself, this is an inactivated vaccine, an annual influenza vaccination for all individuals 6 months of age or older, including pregnancy. High dose is used in patients 65 and older. Live attenuated can be used for annual vaccination ages 2 to 49 years old, and that's intranasal. For timing of the vaccine, the influenza vaccine should be administered annually to everybody 6 months or older, ideally before the onset of influenza activity in the community, by the end of October in the northern hemisphere, and by April in the southern hemisphere. Contraindications are anaphylaxis to the influenza vaccine, Guillain-Barré syndrome within 6 weeks after a previous influenza vaccine, also a current high fever in infants under 6 months of age. And although allergy to protein egg used to be a contraindication, patients with an egg allergy of any severity, including anaphylaxis, can safely receive the egg-based inactivated influenza vaccine in a medical setting supervised by a healthcare provider. Contraindications to the live attenuated vaccine only: immunocompromised patients including HIV, pregnancy, adults 50 or older, individuals who have taken an influenza antiviral medication in the past 48 hours, close contacts and caregivers of severely immunocompromised persons who require a protected environment. Acute bronchitis is next. This is inflammation of the bronchi. Etiology is most commonly caused by viruses like adenovirus, parainfluenza, influenza, coronavirus, Coxsackie virus, rhinovirus, and RSV. For bacterial, there's strep pneumoniae, H. flu, M. catarrhalis, and mycoplasma. Clinical manifestations: the hallmark is cough for acute bronchitis. It may be productive or present for at least 5 days, but it usually lasts 1 to 3 weeks. They may also have some malaise, dyspnea, wheezing, URI symptoms like runny nose or low-grade fever. They may have hemoptysis. Acute bronchitis and bronchogenic carcinoma are the two most common causes of hemoptysis. Very important. Hemoptysis, acute bronchitis, and bronchogenic carcinoma are the two most common causes of hemoptysis. Diagnosis: usually a clinical diagnosis without the need for imaging, and chest radiographs are usually normal or nonspecific if you do get them. Management: symptomatic management, fluids, antitussives, antipyretics, and analgesics. Antibiotics are not usually indicated for most patients. Moving to pertussis or whooping cough. This is a highly contagious infection, secondary to Bordetella pertussis, a gram-negative coccobacillus. It's rarely seen due to widespread vaccination, but most common in children under 2 years of age. The transmission is respiratory droplets during coughing fits, and it has a 7-day incubation period. So importantly, CPC, catarrhal, paroxysmal, and convalescent phase are the clinical manifestations. So first, the catarrhal phase. This is URI symptoms lasting 1 to 2 weeks. It's first, and it's the most contagious phase. Then you have the paroxysmal phase, which are the severe paroxysmal coughing fits with inspiratory whooping after coughing fits. They may have post-coughing emesis as well, and it often lasts a long time, 2 to 4 weeks. There's the convalescent phase as well, the resolution of the coughing stage may last up to 6 weeks. So this is a rather long infection. Diagnosis is clinical. You could also do a throat culture and PCR, and you often see a lymphocytosis, importantly. Throat culture is most sensitive in the first 2 weeks, so that catarrhal phase. And the PCR of the nasopharyngeal swab is sensitive up to 4 weeks, so the catarrhal and the paroxysmal. Management is supportive as the mainstay, like oxygen, nebulizers, mechanical vent if needed. Antibiotics are used to decrease contagiousness of the affected patient. So macrolides are the treatment of choice, like azithromycin. Azithromycin is better tolerated and is preferred in children under 1. Bactrim is also second line. Complications include pneumonia, importantly, encephalopathy, otitis media, sinusitis, and seizures. It's an increase in mortality in infants due to apnea and cerebral hypoxia with the coughing fits themselves. So pertussis prevention. In the US, 5 doses of DTaP is typically recommended at 2, 4, 6, 5 to 18 months and at 4 to 6 years of age. A booster dose is administered between 11 and 18 years of age. So next to go into bronchiolitis. There's a couple different types of bronchiolitis before we go into acute bronchiolitis that we're familiar with. There's bronchiolitis here, bronchiolitis obliterans, which is constrictive bronchiolitis. This is patchy or chronic inflammation and fibrosis of the bronchioles, leading to collapse and obliteration of the bronchioles. Granulation tissue in the bronchial lumen leads to obstructive lung disease. There'll be a mosaic pattern on CT scan. It's most commonly seen with a post-lung transplant rejection, as well as inhalation injuries, like Silo-Filler's disease. Also, for management, it's high-dose corticosteroids and immunosuppression. Lung transplant is definitive. There's also cryptogenic organizing pneumonia, COP, formerly known as bronchiolitis obliterans with organizing pneumonia, BOOP. Persistent alveolar exudates leading to inflammation and scarring, fibrosis of the bronchioles and alveoli. Resembles pneumonia on the chest x-ray but does not respond to antibiotics. The chest x-ray findings that persist despite the clinical improvement of the patient. It's often idiopathic or occurs after pneumonia, and the management of here is still corticosteroids. So both are management of corticosteroids. Next, acute bronchiolitis. This is an infection and inflammation of the bronchioles. Etiology is RSV, respiratory syncytial virus, is the most common cause. Other viruses too, like rhino, adeno, influenza, parainfluenza. Risk factors are very young infants, so 2 months to 2 years are most common affected. Under 6 months of age, exposure to cigarettes, lack of breastfeeding, prematurity and under 37 weeks of gestation, and crowded areas are risk factors. There's typically a viral prodrome of fever, URI symptoms for 1 to 2 days, followed by a respiratory distress, wheezing, tachypnea, nasal flaring, cyanosis, retractions, rales. And if it's getting severe, you may see hypoxemia, apnea, and respiratory failure. The diagnosis is mainly clinical, although chest radiograph can be done, but it will show non-specific hyperinflation, parabronchial cuffing or thickening, atelectasis as well. It's not routinely performed though. Nasal washing using monoclonal antibody testing is also diagnostic, and pulse oximetry is the single best indicator of disease in children. So that's important. Pulse oximetry is the single best predictor of disease in children. Management of acute bronchiolitis. Supportive measures are the mainstay. Humidified oxygen, IV fluids, nebulized saline, cool mist humidifiers. Mechanical vent may be indicated if severe. Medications may play a limited role. Beta agonists, nebulized racemic epi, corticosteroids not indicated unless a history of underlying asthma. And also in ROSH, they said nasal suctioning is the first step for acute bronchiolitis over anything else like SABAs, racemic epi, or corticosteroids. So also make note of suction for acute bronchiolitis. And prevention in high-risk patients, palivizumab during the first year of life can be given for preemies under 29 weeks with symptomatic chronic lung disease of prematurity, congenital heart disease, or neuromuscular difficulties. And also hand washing is preventative. So palivizumab is also called Synagis. Next will be acute epiglottitis, or also called supraglottitis. This is a severe, potentially life-threatening inflammation of the epiglottis. Most common in children 3 months to 6 years, and males are 2 times more commonly to have this. Occurs in any season, and diabetes is a risk factor. Etiologies, Haemophilus influenza B, Hib, historically was the most common cause, although there's now reduced incidence in the U.S. due to Hib vaccination. Hib epiglottitis still occurs, especially in unvaccinated children or foreign immigrants. If they are immunized, streptococcal species are most common, like Group A, Streptococcus, and Strep pneumoniae. Other H. influenza, Staph aureus may occur with cocaine use in adults. So it could be post-strep throat. Clinical manifestations, dysphagia, drooling, and distress, the 3 Ds, dysphagia, drooling, and distress, fever, odynophagia, inspiratory stridor, dyspnea, hoarseness, muffled hot potato voice classically, and also the classic tripoding, very important, sitting leaning forward with the elbows over the lap, refuses to lie supine. For diagnosis, laryngoscopy is definitive diagnosis, in which you'll see a cherry red epiglottis with swelling. This is performed when securing the airway. You can also do soft tissue lateral cervical radiographs, which will show the classic thumb or thumbprint sign, which is the swollen, enlarged epiglottis, but it's not necessary for the diagnosis. And do not attempt to visualize using a tongue depressor in children. So always secure the airway is the first step. Management of epiglottitis. Managing the airway is the most important component of management. Place the child in a comfortable position and keep the child calm to avoid airway issues. The OR is the best setting for intubation, importantly. Dexamethasone for the airway edema in some. And antibiotics. 2nd or 3rd gen cephalosporins like ceftriaxone, cefotaxime, penicillin, ampicillin, or anti-staphylococcal coverage may be added like Vanc. Prevention, rifampin is given to all close contacts. So also the prevention for meningitis in some is rifampin or ciprofloxacin on another note. But rifampin given to all close contacts to prevent acute epiglottitis for somebody who has had this. So routine use of the Hib vaccination is also a part of prevention. Next, laryngotracheitis, or croup. This is inflammation of the larynx and supraglottic airway. Most commonly occurs between 6 months and 6 years, especially in the fall and winter. The etiologies are parainfluenza virus type 1 is the most common cause, also RSV as well, and adenovirus and rhinovirus. Clinical manifestations of croup: upper airway involvement, the classic harsh seal-like barking cough. This is a hallmark of the disease in infants and young children. An inspiratory stridor and hoarseness can be found as well. Dyspnea, low-grade fevers, and symptoms are worse at night. They'll have URI symptoms like coryza during periods after the presentation, and significant upper airway obstruction, respiratory distress. For diagnosis, you want to do it clinically. It's a clinical diagnosis for croup once epiglottitis and foreign body aspiration are excluded, importantly. You can do a front cervical radiograph in which you'll see the steeple sign, which is subglottic narrowing of the airway, looks like a steeple, and this is seen in 50%, but it's rarely done. For management, there's mild, moderate, and severe. For mild management of croup, this is no stridor at rest and no respiratory distress. It will just be supportive. Cool, humidified air mist and hydration. Supplemental O2 in patients with a saturation of O2 under 92%. Also add dexamethasone, which provides significant relief as early as 6 hours after the single dose, can be given orally or IM, which results in faster resolution of symptoms, decreased length of stay, and decreased relapse. Patients can be discharged home with this mild croup. For moderate croup, this is stridor at rest, but they will only have mild to moderate retractions. Again, dexamethasone PO or IM plus supportive treatment, and then here you add that nebulized epi as well. And you should observe them for 3 to 4 hours after clinical intervention with the dexamethasone and epi, and they may be discharged home if improvement is seen. And lastly, for severe croup, this is stridor at rest with marked retractions. You want to do the dex again with nebulized epi and hospitalization. So important to note, the dexamethasone is before the epi, and in moderate you give both, and severe you give both and you hospitalize. So again, for croup, the diagnosis is that classic steeple sign, the narrowing of the trachea, seen on a frontal cervical x-ray, and that's only seen in 50%. And as opposed to acute epiglottitis, which you see the thumb or thumbprint sign, and that's on a soft tissue lateral cervical radiograph. Okay, moving to pneumonia. Pneumonia, so typical and atypical pneumonias. Typical pneumonias, strep pneumoniae is the most common cause. Also, Haemophilus influenza can be seen. That's more common in COPD. Klebsiella in alcoholics. Staphylococcus aureus as well for typical. For atypical, there's Mycoplasma pneumoniae, Chlamydiophila pneumoniae, and Legionella pneumophilia, and also viruses. Remember, Legionella, diarrhea, and hyponatremia. Clinical manifestations of pneumonia: for typical, you get fever, productive cough, pleuritic chest pain, dyspnea, rigors, which are severe chills with violent shaking. This is classically associated with strep pneumoniae. That's rigors with strep pneumoniae. For atypical, they have a low-grade fever, dry, non-productive cough in atypical, and also they'll have extrapulmonary symptoms like myalgias, malaise, pharyngitis, nausea, vomiting, and diarrhea. For physical exam, for typical again, tachypnea, tachycardia, signs of consolidation, bronchial breath sounds, dullness to percussion, increased tactile fremitus, egophony and inspiratory rales, crackles. For atypical, a little bit different. The pulmonary exam is often normal. Signs of consolidation are usually absent here. They may have some crackles. So elderly, diabetics, and immunocompromised patients may have minimal exam findings even with typical pneumonia. So going over some of the findings in pneumonia versus pleural effusion versus pneumothorax or obstructive lung disease on percussion, fremitus, and breath sounds. So for pneumonia, on percussion you'll have dullness. For fremitus in pneumonia, it'll be increased. And for breath sounds in pneumonia, they'll be bronchial and also egophony. For a pleural effusion, the percussion will be dull as well. Fremitus will be decreased, however. Since it's not in the lung, it's around the lung. It's the pleural effusion. And breath sounds will be decreased. For pneumothorax or obstructive lung disease, it'll be hyperresonant on percussion. The fremitus will be decreased as well, and the breath sounds will also be decreased. So some of the microbiology of pneumonia. Strep pneumoniae is the most common cause of community-acquired pneumonia at 65%. The presentation is sudden onset of one-time chills and rigors. This is that violent shivering. Fever, productive cough with blood-tinged, rusty sputum. Also, they're called gram-positive diplococci on gram stain. So, strep pneumoniae, chills and rigors, blood-tinged, rusty sputum. For Haemophilus influenza, this is the second most common cause of community-acquired. The increased risk is extremes of age, so under 6 years old as well as elderly, and immunocompromised like diabetics, HIV, chemotherapy, and also underlying pulmonary disease, so COPD, bronchiectasis, cystic fibrosis, very important, and it's often a colonizer of the respiratory tract, gram-negative rods. So remember, this is also the same bug as epiglottitis as well. Staph aureus, commonly associated with a superimposed infection after a viral infection, so post-influenza bacterial pneumonia. Also hospital-acquired, such as MRSA. Chest radiographs associated with a bilateral, multi-lobar infiltrate or abscess, cavitary lesions in Staph aureus. And the sputum gram stain will show gram-positive cocci in clusters. Also Klebsiella pneumoniae, severe illness and chronic alcoholism importantly, sick patients and patients with chronic illnesses, like diabetics, may present with purple-colored or currant jelly sputum for Klebsiella. Cavitary lesions are hallmark, but nonspecific, and we also saw the cavitary lesions in Staph aureus, or lobar consolidations. And the sputum gram stain will show gram-negative rods for Klebsiella. And for Mycoplasma pneumoniae, so this is an atypical pneumonia. This is the most common cause of atypical pneumonia, Mycoplasma pneumoniae. Risk factors are young and healthy, so you might see it in the vignette as school-aged children, college students, or military recruits. Outbreak is often in the late summer and early fall, as well as crowded areas. Clinical manifestations of Mycoplasma pneumonia: extrapulmonary symptoms, most commonly present with pharyngitis and URI symptoms like rhinorrhea, headache, malaise, fever, followed by a persistent dry, non-productive cough. The physical exam is often normal. Importantly, they sometimes ask bullous meningitis, which are fluid-filled blisters on the tympanic membrane, is a rare non-specific finding associated with mycoplasma. And complications include SJS, importantly, 10, toxic epidermal necrolysis, erythema multiforme, EM, cold autoimmune hemolytic anemia as well. So a few of those they commonly ask about, especially SJS and erythema multiforme for Mycoplasma pneumoniae. So a few things to remember for Mycoplasma pneumoniae. For diagnostic tests overall, on chest radiograph you'll see an atypical pattern. Reticulonodular pattern in Mycoplasma is most common. Diffuse, patchy, or interstitial infiltrates. So that's a little bit different from typical. For Mycoplasma, it's that reticulonodular pattern, which is most common. Also diffuse, patchy, or interstitial infiltrates. The PCR is the test of choice. Also that cold agglutinids, importantly. So that's why you want to look for that cold autoimmune hemolytic anemia, IgM. Cold agglutinids. Management: macrolides, azithromycin, Clarith, or doxy will work. And it lacks a cell wall, so it's naturally resistant to beta-lactams. Moving to Legionella pneumonia, another atypical cause. Legionella is an aerobic, pleomorphic, intracellular gram-negative bacterium. The transmission is outbreaks related to contaminated water sources, especially air conditions, portable water, cooling towers, ventilation systems. No person-to-person transmission for Legionella. Risk factors are immunosuppressed patients, smokers, elderly, chronic lung disease. Manifestations of Legionella, especially GI symptoms: diarrhea, watery and non-bloody diarrhea, nausea and vomiting. Importantly is a higher incidence of hyponatremia and increased LFTs. Also neurologic symptoms: headache, confusion, altered mental status. And although it's atypical, quotes, patients can be very ill. So for Legionella, you want to do for diagnosis a nucleic acid detection. PCR is preferred. You can also do a urine antigen test, importantly. It's bolded, urine antigen test for Legionella. Management, again, macrolides or a respiratory fluoroquinolone like Levo. So important to remember for Legionella, you can do a urine antigen test, but the PCR is preferred. You see hyponatremia, increased LFTs, and neurologic symptoms as well. and know its contaminated water sources as opposed to person-to-person transmission. So going into some more pneumonia, community-acquired pneumonia is acquired outside of the hospital setting and the patient is not a resident of a long-term care facility, such as a nursing home, or 2, the patient was ambulatory prior to admission who developed pneumonia within 48 hours of initial hospital admission. So in its contrast, hospital-acquired or nosocomial pneumonia, this is pneumonia occurring over 48 hours after hospital admission, often caused by Pseudomonas, MRSA, or other organisms found in the hospital. So again, going over a table summarizing the different types. For typical, we have strep pneumoniae, gram-positive, H-flu, gram-negative, Klebsiella, gram-negative, Staph aureus, gram-positive. For the typical, we see lobar pneumonia on chest x-ray. Manifestations of typical are sudden onset of fever, so remember that's that strep pneumoniae, that spiking fever, productive cough and purulent sputum. Remember the rusty sputum for strep pneumoniae. Pleuritic chest pain, rigors again with strep pneumoniae, tachycardia, tachypnea, and on physical exam of typical, we see those signs of consolidation, bronchial breath sounds, dullness to percussion, increased tactile fremitus and gynecophony, inspiratory rales. So for atypical, that's the MCL, Mycoplasma, Chlamydia, and Legionella, and also viruses. So Mycoplasma pneumoniae, Chlamydophila pneumoniae, Legionella pneumophilia. And for this on X-ray, you see diffuse, patchy, interstitial, or importantly, reticulonodular infiltrates. Manifestations are a low-grade fever, dry, non-productive cough, and importantly, extrapulmonary symptoms. Myalgias, malaise, sore throat, hyponatremia maybe. Physical examination, often normal, plus or minus crackles and rales, and signs of consolidation are usually absent in atypical. So going over the treatments based on where they are, so the clinical scenario and then the empiric treatment guidelines we'll go over for antibiotic management of pneumonia. So if they're community-acquired outpatient, you can use a macrolide or doxycycline. Fluoroquinolones are only used first line if comorbid conditions or recent antibiotic use. If they're again community-acquired but they're inpatient, you should use a beta-lactam plus either macrolide or doxy or a broad-spectrum fluoroquinolone. If they're hospital-acquired and Pseudomonas infection is at risk, use an anti-Pseudomonal beta-lactam plus either an anti-Pseudomonal aminoglycoside or fluoroquinolone. You can add Vanc if or linezolid if MRSA is suspected. Add Levo or azithromycin if Legionella is suspected. Add Bactrim plus or minus corticosteroids if PCP is suspected with HIV patients. If a documented beta-lactam allergy, you can use fluoroquinolones, aztreonam, and aminoglycosides. For aspiration pneumonia, we're worried about anaerobes, so you want to use ampicillin sulbactam, which is Unison, or augmented, amoxicillin clavulanate. Hospital-acquired aspiration anaerobes, you can use imipenem, meropenem, or pip/tazo. Drug resistance suspected, you can use any of the following: pip/tazo, cefepime, ceftazidime, imipenem, meropenem, aztreonam, plus one of the following: aminoglycoside, anti-Pseudomonal fluoroquinolone like Cipro, Levo, or a polymyxin as well. So to continue, inpatient therapy is with IV antibiotics. You can change to oral when clinically responding and they're able to tolerate PO. Okay, so the CURB 65 admission criteria is important to know. So that's confusion, uremia, respiratory rate, blood pressure, and age over 65. So if you have at least 2, you want to consider admission. So that's for the uremia, it's over 30 milligrams. For respiratory rate, it's over 30. For BP, that's low. It's a systolic under 90 or a diastolic under 60, and the age is over 65. So that's the CURB 65 for admission criteria for pneumonia. And to cover aspiration pneumonia, this is most commonly caused by anaerobes like Bacteroides, Fusobacterium, and an increased incidence is in periodontal disease, patients with dental disease. Also in chronically ill, gram-negative rods and Staphylococcus aureus may also be present. Pathophys is inhalation of oropharyngeal or gastric microbes. And it's most common in the right lobe. So remember, this is due to the vertical angle of the right mainstem bronchus is more vertical, so it easily goes down there. And also reduced consciousness and protracted vomiting especially are risk factors. It's associated with a foul-smelling sputum, the rotten egg smell, and a pulmonary abscess or empyema can develop as well. The management is ampicillin sulbactam, first line, or amoxicillin clavulanate. So that's Unison or Augmentin. Alternatives are metronidazole plus amoxicillin or penicillin G, hospital-acquired aspiration, imipenem, meropenem, or piptazo, importantly. So histoplasmosis. Histoplasma capsulatum is a dimorphic oval yeast, not encapsulated despite its name. Histoplasmosis is transmitted due to inhalation of soil containing bird or bat droppings in the Mississippi and Ohio River valleys. It's also seen with demolition, people who explore caves, which are called spelunkers, or excavators in those areas. Risk factors for histoplasmosis are immunocompromised, of course, AIDS-defining illness with a CD4 under 150, and usually they're asymptomatic, but they may have some flu-like symptoms. They may have some atypical pneumonia symptoms like non-productive cough, myalgias. If it's disseminated, a risk factor is immunocompromisation and hepatosplenomegaly, fever, etc. It can mimic tuberculosis if it's disseminated histoplasmosis. Labs increased alk phos and LDH. Chest radiograph pulmonary infiltrates, hilar or mediastinal lymphadenopathy. Also, antigen testing via sputum PCR or urine is highly specific. So again, antigen testing via sputum PCR or urine. So we saw that urine test and PCR was also with Legionella as well. Cultures. The most specific test is cultures. For management, asymptomatic doesn't need treatment. For mild to moderate, you want to use itraconazole. And for severe, you want to use amphotericin B. So remember, it is a yeast after all. So itraconazole is the first line, then amphotericin B. So next we'll go over the pneumococcal vaccines. So next for pneumococcal vaccines. Pneumococcal conjugate vaccine, the PCV13. This protects against 13 serotypes that account for 85% of the serotypes causing invasive pneumococcal infections, including meningitis and bacteremia. The administration is in patients 6 weeks through 5 years old. It is administered as a part of a 4-dose immunization series given at 2, 4, 6, and 12 to 15 months of age. May be indicated in older high-risk patients as well for the PCV13. The PPSV23, the pneumococcal polysaccharide vaccine, is indicated in all adults 65 and older, as well as younger patients with conditions that increase the risk for developing complications from pneumococcal infections, such as pneumococcal pneumonia or invasive pneumococcal disease. So all patients who receive PPSV23 before age 65 should be revaccinated at age 65 unless the vaccine is given under 10 years prior to the patient turning 65, in which the patient should be revaccinated 10 years following the first dose. If both vaccines are recommended, then the patient should receive them as follows. 1. The patient has had no prior vaccination with either vaccine. The patient should receive a single dose of PCV13 followed by 8 weeks later by PPSV23, or the patient has received PPSV23 in the past. A single dose of PCV should be given 1 year after the administration of PPSV23. Contraindications: severe allergic or anaphylactic reaction to any component or formulation of the vaccine or diphtheria toxoid containing vaccine. And pregnancy is not a contraindication. Next, PCP, Pneumocystis pneumoniae. Pneumocystis jirovecii, which is formerly called Carini, is a yeast-like fungus that doesn't respond to antifungals. Transmission is inhalation. Risk factors are immunocompromised states, especially HIV, malignancy, chemotherapy, transplant recipients. Most common opportunistic infection in HIV, especially with a CD4 under 200, very important. Most common in HIV, opportunistic infection with a under CD4 of 200. Manifestations are a triad of dyspnea on exertion, fever, and a non-productive cough. Oxygen desaturation with ambulation. For diagnosis, chest radiographs will show diffuse bilateral interstitial infiltrates, but they may be normal as well, And importantly, something that you can note is increased LDH over 200 and an increased beta-D glucan. So increased LDH importantly. You can do a bronchoalveolar lavage specimen or induced sputum or a direct fluorescein antibody staining of the sample to see trophic and cyst forms are the most common technique. Lung biopsy is definitive but rarely performed. Management is trimethoprim sulfamethoxazole, which is Bactrim, which is the drug of choice, and you do it for 21 days. If they're HIV positive, add prednisone if they're hypoxic, importantly, with a PaO2 of under 70 millimeters of mercury, or an A to A gradient of over 35 to decrease mortality. You can also use IV pentamidine in some severe cases, and for sulfa allergy, use dapsone, trimethoprim, clinda, primaquine, or atovaquone, or IV pentamidine. So they asked that on ROSH, should you do Bactrim plus prednisone or just Bactrim? So if they're hypoxic, you use the prednisone as well, and that's considered a PaO2 of under 70 millimeters of mercury. That's how you determine it. And second line is that IV pentamidine as well. So for patients with G6PD deficiency, mild disease, you want to use atovaquone. Moderate and sulfa-tolerant patients, you can use atovaquone, Bactrim, or IV pentamidine. Avoid dapsone or primaquine. So remember your causes of drug-induced G6PD exacerbation, DNP, dapsone, nitrofurantoin, and primaquine. So you want to avoid that dapsone and primaquine here with the G6PD deficiency. So again, for PCP prophylaxis, you want to do Bactrim in patients with a CD4 under 200. And PCP pneumonia may have a normal chest x-ray, 10 to 40% of the cases, but when there is a positive finding, the classically chest x-ray will show bilateral, diffuse, symmetric, finely granular opacities in a reticular interstitial airspace pattern. That's 80%. So bilateral, diffuse, symmetric, finely granular opacities, reticular interstitial airspace disease. Often associated with central location, and it can resemble a non-cardiogenic pulmonary edema. So next, moving to tuberculosis. This is an infection of the respiratory system with Mycobacterium tuberculosis. The transmission is inhalation of airborne droplets. Pathophys is after inhalation. Mycobacterium tuberculosis goes into the alveoli, gets incorporated into macrophages in the alveoli, and can disseminate from there. Risk factors, importantly, are close contact with someone infected with TB, immigrants from a highly endemic region, crowded conditions like prisons or shelters, healthcare workers, and immunosuppression. TB and HIV infection, 7 to 10% yearly chance of reactivation of latent TB, importantly. Outcome of infections with TB, primary TB. The outcome of initial infection, which is usually self-limited due to the body's immune reaction. Primary rapidly progressive TB. This is an active initial infection with clinical progression, however. These patients are contagious. It's common in children under 4 years old and in endemic areas. So if the immune system can't handle it when you first get it, then it becomes primary and also rapidly progressive. And that's more common in children under 4, or of course immunosuppression. Chronic latent infection, 90% of control initially with the primary infection via a caseating granuloma formation. So the body actually forms that caseating granuloma around the TB. These granulomas may become caseating, central necrosis, and acidic with low oxygen, making it hostile for MTB to grow. Usually the PPD is positive at 2 to 4 weeks after infection. Needed all three things to show infected with TB but not infectious. For 1, a positive PPD, 2, no symptoms, and 3, no imaging findings of active infection on X-ray. So you need those three things to show that it's latent. Positive PPD, no symptoms, no X-ray findings. Secondary reactivation TB, reactivation of latent TB with waning immune defenses, such as elderly, HIV, steroid use, malignancy, 5 to 10% lifetime incidence. Most commonly located in the apex, upper lobes with cavitary lesions due to the increased O2 content of the lung apices. These patients are contagious if it's reactivation TB. So remember, in reactivation, it's those apices that are affected. But for primary TB, It may not be the apices, importantly. Clinical manifestations of TB: pulmonary, you'll have the cough, non-productive or productive, hemoptysis, fever, chills, night sweats, chest pain. Extrapulmonary symptoms, importantly, they can affect any organ, so you need to know scrofula, which is cervical lymph nodes affected in TB, meningitis, as well as Pott's disease, which is TB of the vertebrae, miliary TB, which is like little millet seeds seen on chest x-ray, pericarditis, TB can go to the pericardium, adrenal involvement or GU involvement. For diagnosis, chest radiograph is often the initial test ordered. For reactivation, like we said, the apical or upper lobes will be affected. Primary TB, like we said, middle and lower lobes will have consolidation. Miliary TB is when the chest x-ray shows a millet seed-like nodular lesion. And TB pleurisy is a pleural effusion caused by TB infection. So that would be a exudative, not transudative. Granuloma, residual evidence of healed primary TB. So a Ghon's complex. Ghon's complexes in a granuloma formation are calcified primary focus plus a lymph node. Also the Ranks complex, healed fibrocalcific Ghon complex seen on chest x-ray. So also other things you can do for diagnosis are sputum acid-fast staining. So when you do this, it's 3 samples taken on 3 consecutive days, which must be negative to rule out TB. Only 1 positive sample, however, is needed to rule in TB. Early AM gastric specimens if unable to give sputum. Sputum cultures can also be diagnostic with at least 3 samples on 3 consecutive days, again, preferably early morning, and nucleic acid amplification as well, which is more sensitive than the sputum smears as well. Management of active TB, you want to do your 4-drug therapy, RIPE, rifampin, isoniazid, pyrazinamide, and ethambutol for 2 months, followed by 4 months continuation phase with rifampin and isoniazid, pending the sensitivity. So it's a 6 months total duration of treatment. First 2 months, you get all of them, and then 4 months, you continue rifampin and isoniazid. So if they have some kind of eye problem or you can't use ethambutol, you can use streptomycin instead. So to go over some of the adverse effects and considerations with each of those drugs, they often ask that. So rifampin is thrombocytopenia and flu-like symptoms. Also importantly, the orange-colored secretions with rifampin. And the mechanism of rifampin is it inhibits RNA synthesis, and it's contraindicated in patients taking protease inhibitors or NNRTIs, such as in HIV. Isoniazid, INH, hepatitis is an adverse effect, especially in over 35 years, and importantly, peripheral neuropathy, very important, and cytochrome P450 inhibition as well. So with isoniazid and also high anion gap acidosis, remember it's part of the Mudpilers mnemonic. So for isoniazid, mechanism inhibits mycolic acid synthesis, and very importantly, peripheral neuropathy prevented with pyridoxine, which is B6. Baseline LFTs are also recommended. So, and pyrazinamide, hepatitis and hyperuricemia, H&H for pyrazinamide, hepatitis, hyperuricemia, also a photosensitive dermatologic rash for pyrazinamide. Caution in gout and liver disease, of course, with pyrazinamide. Ethambutol can be remembered as ithambutol with eye problems. That's optic neuritis and peripheral neuropathy again, but not as much as INH with that peripheral neuropathy. And streptomycin is ototoxic to cranial nerve 8 and nephrotoxic. Remember, streptomycin is the aminoglycoside. So don't forget rifampin, most importantly, colored orange secretions. Isoniazid, that peripheral neuropathy that you can be prevented with B6, pyridoxine. Pyrazinamide, hepatitis and hyperuricemia and photosensitive rash. Ethambutol, ithambutol, optic neuritis. So treatment of latent TB infections, LTBI. The scenario is if they have a likely INH sensitivity, you want to do INH plus pyridoxine, of course, the vitamin B6 for 9 months. Remember, in latent TB, 9 months. You could also do rifampin plus 4 months of INH plus rifapentine. If they have latent TB diagnosis, it must meet all these 3 criteria. Again, like we said, for latent TB diagnosis, they must be asymptomatic, a positive PPD, and no evidence of active infection on chest X-ray or CT, and these patients are not contagious. So treatment of latent TB reduces the lifetime risk of reactivation from 10% to 1%. So sometime you're going to become immunocompromised and you have an increased risk of lapsing into a reactivation TB. So it's important to go over the TB screening for infection. For this, we use the purified protein derivative, the PPD test, and we examine 48 to 72 hours for transverse induration, not redness. And transverse induration is considered positive, not just redness. Any positive PPD should be followed by a chest x-ray to rule out an active disease. So going over the size and the person's consideration to having a positive test. If they have 5 millimeters or greater, this would be in patients with HIV or immunosuppressed, such as prednisone for over a month. Also close contacts with a patient with TB. Chest x-ray consistent with an old or healed TB, such as a calcified granuloma. For greater than or equal to 10 millimeters on PPD, this is all other high-risk populations or high prevalence populations, or recent conversion, increase in duration by over 10 millimeters in the past 2 years. So over 15, greater than or equal to 15 millimeters on PPD is everybody else. So it's important to know some false negative things, anergy, HIV and sarcoidosis, as well as faulty application if it's given SQ instead of transdermal. False positives, improper reading, like they might think that it's just the redness as opposed to the transverse induration. False positives, improper reading, cross-reaction with an atypical, such as Mycobacterium avium complex, or within 2 to 5 years or 2 to 10 years of the BCG vaccine. Also note the booster effect. This is when the infected person's immune system forgets about TB until years later when testing reminds the immune system. The next PPD will be positive because the initial infection years ago, not because of the recently converted infection. Confirmed by a 2-step PPD testing if you think they have this thing. So also note, history of a previous BCG vaccine has no impact or effect on recommendations for screening and treatment of latent TB infection in adults. So IGRA, interferon gamma release assay. This is a blood test with improved specificity, no reader bias, no booster phenomenon, and not affected by prior BCG vaccination. So this is important that IGRA is the best test. And again, chest radiograph used in PPD positive patients who require yearly screening, such as healthcare workers. So again, just to run through some of the findings in TB, we have the classic miliary TB, which is the diffuse millet seed appearance, infiltrates in the lung fields. The classic primary is the lower lobe consolidation. And the classic reactivation is infiltrates and cavitation in the upper lobes. Now moving to a solitary pulmonary nodule. This is a single, small, 30 millimeters or less than 3 centimeters, usually well-circumscribed lesion that is surrounded entirely by pulmonary parenchyma. The etiologies of a solitary pulmonary nodule are infectious granuloma as most common, which is over 75% of all benign nodules, especially mycobacteria, tuberculosis and fungi, histoplasmosis and coccidiomycosis. Maybe benign or malignant, lung cancer, metastasis, carcinoid tumors. Thymoma is the most common mediastinal tumor. So it's important to differentiate which are malignant and which are not. So those at increased risk of malignancy are spiculated nodules that are larger than 2 centimeters. They have irregular borders. They have asymmetric calcifications. They have upper lobe locations for the increased O2 content. They're over 40 years old, or the older they are, the more likely it's malignant. They have a history of smoking. The lesion is enlarged, like we already said, over 2 centimeters. And they have an abnormal PET scan. Decreased risk will be a well-circumscribed, smooth borders, small, under 1 centimeter, dense, diffuse calcification, under 30 years of age, non-smoking, and no change in size, and a normal CT as well. For diagnostic workup, no matter what it is, you want to do a chest radiograph. Is usually the initial test that reveals the pulmonary nodule in the first place. Then you can do a CT of the chest. This is the imaging of choice to determine the likelihood of malignancy of the nodule found incidentally on that chest radiograph. For management, for low probability, you can just do active surveillance and with monitoring for changes. Intermediate, you can do bronchoscopy if the lesion is central. Transthoracic needle aspiration for a peripheral lesion as well. And if it's a high risk, then you can do a resection with a biopsy. Next will be bronchial carcinoid tumors. These are rare neuroendocrine tumors from the enterochromaffin cells that are characterized by slow growth, low metastasis, and are usually well differentiated. The GI tract is the most common site for carcinoid tumors, and the lung is the second most common. May secrete serotonin, ACTH, ADH, or melanocyte-stimulating hormone, and they're most common in under 60-year-olds. So serotonin most common for that carcinoid tumor. Manifestations: focal wheezing, cough, hemoptysis, SIADH, Cushing syndrome, obstruction. But you also have, importantly, for bronchial carcinoid tumors, that serotonin syndrome-like presentation. So it's called carcinoid syndrome. It's rare but classic. There's periodic episodes of diarrhea due to the serotonin release, flushing, tachycardia, and bronchoconstriction due to the histamine release, and hemodynamic instability like hypotension. So again, diarrhea, flushing, bronchoconstriction, and hemodynamic instability is that carcinoid syndrome. For diagnosis, on bronchoscopy, pink to purple, well-vascularized, centrally located tumor. And for management, surgical excision is the definitive treatment. Tumors are often resistant to radiation and chemo. And also octreotide may be used to reduce symptoms as it decreases the secretion of active hormones. Next will be bronchogenic carcinoma. Second most common cancer diagnosed in the U.S. after prostate in men and breast in women. Most common cause of cancer-related deaths in the U.S. Greatest tendency for mets to the brain, bone, liver, lymph nodes, and adrenals for bronchogenic carcinoma. Risk factors: smoking is the most common cause, including secondhand, and smoking is associated with over 90%. The exception is the lipidic pattern. Asbestosis is the second most common cause, importantly, so remember mesothelioma. And note that asbestosis and smoking are synergistic effects, so way increase your chances. Radon exposure is also an important cause, and idiopathic pulmonary fibrosis, TB, COPD, all with increased risk. So it's divided into two main types, the non-small cell and the small cell. So the non-small cell has three within it: adenocarcinoma, which again is more common in non-smokers, large cell, squamous cell, and lipidic pattern. And this is usually treated with a surgical resection. And then there's also the small cell cancer. Because it is usually metastatic at the time of presentation, chemo is the initial treatment of choice for most, with or without radiation. So chemo for small cell, and for large cell, usually surgical resection. Or we can also call it non-small cell. So lung cancer screening, importantly, 55 to 80 years old. So the USPSTF recommends annual low-dose CT screening. So that's annual, every year, low-dose CT screening for those 55 to 80 who have no symptoms of lung cancer, but they do have a 30-pack year smoking history, who currently smoke or have quit within the past 15 years. So somebody who has quit over 15 years ago, do not screen them. Screening should be discontinued once a person has not smoked for 15 years or develops a health condition that substantially limits life expectancy or the ability or willingness to undergo curative surgery. So moving to each of those specific cancers more specifically. First, adenocarcinoma of the lung. This is the most common primary lung cancer in smokers, women, men, and non-smokers. So interesting fact, it's also most common in non-smokers, and it's the most common in smokers. So risk factors: smoking is again the strongest risk factor. Also those occupational hazards, radon, etc. Characteristics: typically peripheral, arises from the bronchial mucosal glands. This is a type of non-small cell lung cancer. With the new classification, bronchioalveolar carcinoma and mixed subtypes of adenocarcinoma are eliminated. Lipidic has been used to describe the non-invasive growth along intact alveolar septi, performed bronchioalveolar. Okay, so the lipidic pattern is a rare, low-grade subtype. It has the best prognosis, and it classically presents with voluminous sputum, an interstitial lung pattern on chest x-ray. So you can remember the adenocarcinoma is peripheral due to the alveolar involvement. So it involves the alveoli, so it can't be really central like small cell is. Clinical manifestations: asymptomatic, cough, hemoptysis, weight loss, importantly. And on histology, you'll have the gland formation and mucin production. So that's in bold. So for adenocarcinoma, the mucin production and gland formation. And you want to do surgery, surgical resection in most cases. Next will be the squamous cell lung cancer. Tumor arises from the proximal portions of the tracheobronchial epithelium. Most are bronchial in origin, classified as a non-small cell. Second most common cause of lung carcinoma after adenocarcinoma. Again, smoking strongly associated. And for small cell, or for squamous cell rather, you have to know CCCP. It's centrally located, it has cavitary lesions, it has hypercalcemia, and it has Pance syndrome. So if they ask you about anything that would involve Pance syndrome, you want to think squamous cell carcinoma, not small cell, even though small cell has other paraneoplastic manifestations. The Pance syndrome is that tumor in the upper apices. That's squamous cell. So again, for characteristics of squamous cell, CCCP, typically centrally located and may be associated with a widened mediastinum, associated with cavitary lesions, hypercalcemia, and Pance syndrome. So diagnosis, sputum, and biopsy can be done. So moving to small cell, or called oat cell carcinoma, this is an aggressive type of lung cancer associated with early metastasis. It comprises about 15% of all lung cancers. Risk factor is cigarette smoking, has the strongest association with small cell lung cancer and squamous cell, and also males. So again, the typical symptoms: cough, chest pain, dyspnea, hemoptysis, weight loss, and also the important paraneoplastic syndromes of small cell. This is the superior vena cava syndrome, which it pushes on the superior vena cava, leading to increased JVP. SIADH, leading to hyponatremia, syndrome of inappropriate ADH secretion. Cushing syndrome, importantly, ectopic ACTH secretion. And Lambert-Eaton myasthenic syndrome, LEMS. So that's the similar thing to myasthenia gravis, except it gets better with movement. Small cell lung cancer is the most common solid tumor to present with paraneoplastic syndromes. So again, important to differentiate squamous cell with its CCCP versus small cell with its paraneoplastic syndromes. So diagnosis of small cell: chest radiographs show a mass that's centrally located, but CT is often better. Biopsy is the best, of course, usually CT guided via bronchoscopy if it's central. And on histology of small cell, you see sheets of small dark blue cells with a rosette formation, about 2 times the size of lymphocytes. And the size of the cell primarily distinguishes small cell from non-small cell. And of course, for the management of small cell, chemotherapy is the treatment of choice, because they are often metastatic at the time of presentation. So no surgery. Okay, so we'll actually go into those paraneoplastic syndromes that we talked about in small cell carcinoma again. So, set of systemic symptoms and or signs due to tumor release of hormones and cytokines or by an immune response against the tumor. So again, the examples are superior vena cava syndrome, SIADH leading to hyponatremia, Cushing syndrome, and Lambert-Eaton syndrome. Small cell lung carcinoma is the most common solid tumor to present with paraneoplastic syndromes. So, going into SVC syndrome, superior vena cava syndrome. Signs and symptoms due to partial or complete extrinsic obstruction of blood flow through the superior vena cava. Etiologies: small cell bronchogenic carcinoma, most common. Also Hodgkin's lymphoma, metastatic tumors, and SVC stenosis. Clinical manifestations are dilated and prominent neck and chest veins, importantly. Also a facial plethora, so basically an engorged face. Headache, facial or neck swelling as well. Diagnosis is by chest radiograph, will show right hilar mass widening of the mediastinum, and CT is also better. Management is supportive and treat the underlying cause, elevation of the head, endovascular management as well. Lambert-Eaton myasthenic syndrome is next. These are antibodies against the presynaptic voltage-gated calcium channels, preventing acetylcholine release, leading to muscle weakness. So it's the calcium channels that actually open up to allow the acetylcholine out of the presynaptic cell. So if we just shut these things, there's no ACH that can go out. But it's not a problem with ACH itself, as it is in myasthenia gravis. So this is most commonly associated with small cell lung cancer and other malignancies. And for clinical manifestations of LEMS, you'll have that proximal muscle weakness that improves with repeated muscle use, unlike myasthenia gravis. So don't get confused with that proximal muscle weakness of like polymyalgia rheumatica or poliomyositis. This is different. So the weakness is proximal muscles, and it may cause difficulty arising from a chair, gait alteration, or managing stairs. There's autonomic symptoms like dry mouth, which is most common, physical exam hyporeflexia, sluggish pupillary response, but no muscle atrophy. Diagnosis is a voltage-gated calcium channel antibody assay and electrophysiology, so reproducible post-exercise increase in compound muscle activation on repetitive nerve stimulation testing. So it basically just gets better when you keep on stimulating the muscle. And you can also do a CT scan to assess for underlying malignancy. For management, you want to treat the underlying cause, of course, which is the malignancy. And the medical management is pyridostigmine, or diaminopyridine. But remember pyridostigmine, and you can use that also for ACH stuff too. Second line is plasmapheresis, IVIG, or oral immunosuppressants. So we'll continue along to the superior sulcus or Pancoast tumors. These are tumors located in the superior sulcus near the apex, characterized by a distinct pattern of signs and symptoms. The diagnosis of Pancoast tumor is determined by the location, not the histology. So remember, CCCP, squamous cell carcinoma, is the most common for that Pancoast tumor. Non-small cell lung carcinoma is over 95% of all cases. Pathophys is the tumor compression of the lower brachial plexus, the ulnar nerve, and or the cervical sympathetic nerve chain. So if we know where it is, then we're able to see where the clinical manifestations would arise from. So of course, we'd have shoulder or arm pain as the most common initial symptom in the distribution of C8, T1, and T2 dermatomes. Also the classic Horner syndrome, the triad of ipsilateral ptosis, meiosis, and anhidrosis. So Horner syndrome, ptosis, meiosis, anhidrosis may be preceded by ipsilateral flushing and facial diaphoresis. Weakness or atrophy of the muscles of the hand or the arm may have an ulnar neuropathy as well. Think about where it is in that ulnar area. Because of the tumors are usually peripheral, pulmonary symptoms can also be there, but they're uncommon until the disease advances. So for Pancoast tumors, chest radiograph is often the initial test ordered, but MRI is better. Needle biopsy is definitive. Options include combination of chemo, radiotherapy, and surgical resection. Next for mesothelioma. This is a tumor originating from the pleura, 80% are plural, and there can also be peritoneum, tunica vaginalis, or pericardium. 3/4 are malignant, and the prognosis is very poor if they are malignant. So 80% are due to chronic asbestos exposure. Remember, it's synergistic with smoking in a bad way. Clinical manifestations are pleural mesothelioma, pleuritic chest pain, dyspnea, fever, night sweats, weight loss, and hemoptysis. For diagnosis, chest radiograph will show unilateral pleural thickening with pleural plaques in asbestosis. And also pleural effusions are possible, bloody. Pleural biopsy, closed video-assisted thoracoscopy, which is called a VATS procedure, or an open thoracotomy. Management of mesothelioma is combined approach, which may include chemotherapy, platinum agents plus pre-Metrext, macroscopic complete resection with either pleurectomy or decortication of radical extrapleural pneumonectomy. Non-surgical candidates need systemic chemo or palliative radiation therapy. So for foreign body aspiration, this is aerodigestive foreign body causing varying amounts of obstruction in the airway. Common items include food, coins, toys, food, and balloons. Peanuts are the most common foreign body aspirated in children. Mean age is 2, as the incisors are usually used to bite the food, but absence of molars make it difficult to grind the food. So the main cause of death is due to hypoxic ischemic brain injury and less commonly pulmonary hemorrhage. Complications include bronchiectasis, because it can get stuck in there, pneumonia, lung abscess, and atelectasis. Most common on the right side, which is of course due to the wider, more vertical, and shorter main bronchus. The position may also influence the location. Supine, the most common in the superior segment of the right lower lobe. Sitting and standing, most common in the posterobasal segment of the right lower lobe. And if they're lying on the right side, it's most common in the right middle lobe or posterior segment of the right upper lobe. Clinical manifestations are asymptomatic or a sudden onset, importantly a sudden onset of choking, cough, or dyspnea. So you want to look for the acuity and the age of the patient to see if you should consider a foreign body aspiration. Physical examination, wheezing or asymmetric breath sounds. For diagnosis, chest radiographs will show air trapping, most common finding in children. Normal chest radiograph does not rule out the foreign body as well, and you may order additional neck films. CT may be indicated in symptomatic with negative radiographs, and a rigid bronchoscopy, importantly, a rigid bronchoscopy for foreign body aspiration is the definitive diagnostic test. It's also therapeutic because you can remove the object through this, and it's flexible, which you should use rather than a rigid bronchoscopy. May be used for diagnostic purposes in cases where the diagnosis is not clear, or if the foreign body aspiration is known but the location is unclear. So management of the foreign body aspiration, you want to do, of course, the removal of the foreign object via the rigid bronchoscopy, thoracotomy if refractory to bronchoscopy. But in an acute choking episode, the Heimlich maneuver should be performed. Emergency tracheostomy is performed if the Heimlich maneuver is not successful. Next will be costochondritis and Tietze syndrome. Tietze syndrome. Costochondritis and Tietze syndrome are basically the same thing, except costochondritis has the reproducible point chest wall tenderness, and it's many more areas than Tietze syndrome. It also has the absence of palpable edema, helps distinguish costochondritis from the less common Tietze syndrome, and no edema as well. So just going over them fully, costochondritis is an acute inflammation of the costal cartilages or costochondral junctions. The etiologies are often idiopathic, but can occur post-viral or post-traumatic, like physical strain or excessive coughing. Pleuritic chest pain may be worse with inspiration, coughing, or certain body movements. And on physical exam of costochondritis, there'll be the reproducible chest wall tenderness with palpation, most commonly involving the 3rd, 4th, and 5th sternocostal joints. That's 3 joints there. The absence of palpable edema helps to distinguish costochondritis from the less common Tietze syndrome. And diagnosis is usually a diagnosis of exclusion. This is after everything's been done. Labs, EKG, radiograph, PE, physical exam. Tietze syndrome is, again, pleuritic chest pain in the same area. It's reproducible, point chest wall tenderness, but it also has palpable edema as well. It most commonly involves the 2nd and 3rd costochondral junctions. So costochondritis, again, more areas of reproducible chest wall tenderness and no edema, whereas Tietze syndrome will have edema. Next will be pleural effusion. A pleural effusion is an abnormal accumulation of fluid in the pleural space, not a disease itself, but a sign of disease. Types are parapneumonic, which is non-infected pleural effusion secondary to a bacterial pneumonia. It could be an empyema, which is direct infection of the pleural space, grossly purulent or turbulent effusion, hemothorax in gross blood loss, chylothorax, which is increased lymph associated with persistent turbidity after centrifuge. Etiologies, of course, transitate versus exudate. For transitate, the CHF is the most common cause in over 90%. It could be due to nephrotic syndrome or cirrhosis, also less commonly atelectasis, hypoalbuminemia. So we're losing that oncotic pressure in the blood, and all the water can easily extravasate into the pleural space. So exudate is caused by any condition associated with an infection or inflammation. It contains plasma, proteins, white blood cells, platelets, and RBCs in exudate. Pulmonary embolism, which is rarely transitive, and also malignancy. Presentation overall, clinical manifestations could be asymptomatic, some pleuritic chest pain or cough. On physical exam, there'll be dullness to percussion, decreased fremitus, And remember, increased fremitus in pneumonia in the lobar consolidation, but for pleural effusion, we have decreased fremitus because it's not actually inside the lung itself. Decreased breath sounds as well, and they may have a pleural friction rub. Chest radiographs are the initial test of choice, and we have blunting of the costophrenic angles, which is the meniscus sign. In the lateral decubitus, it's also helpful to differentiate locations, or rather loculations, from the empyema and detect smaller effusions. In extreme cases, it may cause a lung collapse or a mediastinal shift to the contralateral side. So if we do a PA or lateral film, over 175 cc's can obscure the lateral costophrenic sulcus. 500 cc's for the diaphragm. And blunting of the costophrenic angles is the positive meniscus sign again, and plus or minus loculations can be seen. On a lateral decubitus film, this is the best way to determine it. It detects smaller effusions and differentiates loculations and empyema from effusions or scarring. Because if you do it in the lateral decubitus film, if it's just the fluid, it's going to be able to kind of flow to the area of dependency, as opposed to a loculation or an empyema, which is going to be more staying in that same location. Thoracentesis is the diagnostic gold standard. Can be diagnostic and therapeutic. It helps to distinguish between transitive and exudative. Not usually performed if the cause is clear. And importantly, we must know Light's criteria is an exudate if it presents with any of these three, such as a pleural fluid protein, which is a serum protein over 0.5, or a pleural fluid LDH, an LDH over 0.6, or a pleural fluid LDH up of the 2/3 upper normal limit of LDH. So it's a exudate if it's protein, LDH, or high LDH ratio compared to the serum. CT scan or ultrasound may be helpful for additional information, especially if an empyema is present. And for management, you want to treat the underlying cause as the disease, as the mainstay, as it's the sign of an underlying disease. Thoracentesis can be done. It's diagnostic and therapeutic, but it's not always needed. And you never remove over 1.5 liters during any one procedure. Chest tube fluid drainage if the empyema, pleural fluid pH, is under 7.2, glucose is under 40, or a positive gram stain or pleural fluid. You may inject with streptokinase to facilitate breakup of the loculations, interestingly. Remember, streptokinase is the type of thrombolytic. So empyema is pleural fluid under pH of under 7.2 and a glucose under 40. So remember, the bacteria are eating up all that glucose. Pleurodesis for management of pleural effusion can be done, and this is if it's malignant or if you have chronic effusions. Talc is the most commonly thing used, and you could also use actually doxycycline or minocycline. And pleurodesis is basically connecting the pleura to the chest wall so it doesn't move anymore. Okay. So pneumothorax is next. Pneumothorax is air in the pleural space leading to collapse of the lung from a positive intrapleural air pressure. Types, there's many types of pneumothorax. Primary spontaneous, PSP. This is an atraumatic and idiopathic with no underlying lung disease due to a bleb rupture. It mainly affects tall, thin men, 20 to 40 years of age, smokers, and family history of pneumothorax, importantly. SSP, secondary spontaneous pneumothorax, is a cause of underlying lung disease, so if they have COPD or asthma beforehand. You could also have a traumatic pneumothorax, which could be iatrogenic, which could occur during CPR if you break a rib and puncture, or thoracentesis, or a PEEP ventilation, positive end expiratory pressure ventilation could pop it. Also subclavian line placement, car accidents as well for traumatic. And importantly, tension pneumothorax. Any type of pneumothorax in which positive air pressure pushes the trachea, great vessels, and heart to the contralateral side. So air coming in from one side has no out valve in that same area, so it continues to push everything to the other side. Catamenial occurs during menstruation. Ectopic endometrial tissue in the pleural space, interestingly. Also, for clinical manifestations of pneumothorax, you have that chest pain, which is sometimes pleuritic, unilateral, non-exertional, and sudden. For physical exam, hyperresonance to percussion, decreased fremitus, decreased breath sounds over the affected area. And if you have a tension pneumo, you have that increased JBP, due to pushing over, systemic hypotension, and pulsus paradoxus. So remember, due to the heart's inability to continue filling, we have a drop in that systolic pressure of over 10. So for chest radiographs, that's a diagnostic choice of test. Expiratory upright view is preferred. You have decreased peripheral markings due to collapsed lung tissue and companion lines, visceral pleural lines running parallel with the ribs. Also a deep sulcus sign on supine film. So chest radiograph, you want to do an expiratory upright view, and you see the companion lines and the deep sulcus sign. Management of a small PSP under 3 centimeters from chest wall at the apex. You can just do observation and supplemental oxygen if it's small and it's the first episode. So under 15 to 20% of the diameter of the hemithorax, or less than 3 centimeters between the chest wall and the lung on chest x-ray. May be discharged if stable, and repeat films after 6 hours excludes progression. Chest tube thoracostomy if worse on repeated films. If you have a large spontaneous pneumothorax, which is over 3 centimeters from the chest wall at the apex, you should do a needle or catheter aspiration versus a chest tube or catheter thoracostomy. If you have a stable secondary spontaneous, you should do a chest tube or catheter thoracostomy plus hospitalization, as there's probably an underlying cause for this since it's secondary. And for tension, you want to do immediate needle aspiration followed by a chest tube thoracostomy. For others, thoracostomy may be indicated if there's a persistent leak after the chest tube placement or no regression with the chest tube. And again, if you have persistent or recurrent pneumothorax, you can do video-assisted thoracoscopic surgery or thoracotomy. That's, again, the VATS procedure. And again, patient education is important with pneumothorax. You want to tell them to avoid pressure changes for a minimum of 2 weeks, so no high altitudes, no smoking, and also unpressurized aircrafts and scuba diving. So next will be pulmonary hypertension. So pulmonary hypertension is an elevated mean pulmonary arterial pressure over 20 millimeters of mercury with the pulmonary vascular resistance over 3 Wood units. The pathophys is due to increased pulmonary vascular resistance leading to right ventricular hypertrophy, increased right ventricular pressure, and eventually right-sided heart failure. So you can have primary and secondary for pulmonary hypertension. Primary pulmonary hypertension is idiopathic, most common in middle-aged or young women. The mean age of diagnosis is 50 years old. There could be a gene defect as well. In secondary, it's pulmonary hypertension due to pulmonary disease like sleep apnea, PE, cardiac, metabolic, or systemic disease. Classification 1 through 4 of pulmonary hypertension. So class 1 is idiopathic pulmonary arterial hypertension, which is primary. And again, this is the diagnosis of exclusion. For 2, stage 2 classification of pulmonary hypertension, it's due to left heart disease. For stage 3, it's due to hypoxemic or chronic lung disease like COPD. And stage 4 classification of pulmonary hypertension is due to a thromboembolic disease. So 1 is idiopathic, 2 is left heart disease, 3 is hypoxemic or chronic lung disease, and 4 is thromboembolic disease. Clinical manifestations are dyspnea, chest pain, fatigue, weakness, cyanosis. In a physical exam for pulmonary hypertension, you see that accentuated S2. So remember, the hypertension in the pulmonary vessels pushes back and closes the pulmonary valve harder and stronger than it typically would. So this is a prominent P2 and accentuated S2 in pulmonary hypertension, and it may have a fixed or paradoxically split at P2. So you also have signs of right heart failure, increased JVP, peripheral edema, and ascites as well. Pulmonary regurg is possible, a right ventricular heave, and a systolic ejection click. So everything's happening on that right side of the heart as it can't really push through those hypertensive lungs. Diagnosis: chest radiograph, enlarged pulmonary arteries, interstitial or alveolar edema, signs of right-hearted heart failure. EKG will show cor pulmonale with right ventricular hypertrophy, right axis deviation, right atrial enlargement, so you want to look at those P waves, and right bundle branch block is possible. On echo, large right ventricle, right ventricular hypertrophy, and a right heart cath is the definitive diagnosis. This is the gold standard, the right heart catheterization. You'll have the elevated pulmonary artery pressure right ventricular pressure, and increased pulmonary vascular resistance. CBC, you'll have polycythemia due to the chronic hypoxia with an increased hematocrit. Remember that stimulation of hematopoiesis as well. For management, you want to correct the underlying cause if you can, and primary pulmonary hypertension is managed by vasoreactivity trial with an inhaled nitric oxide, IV adenosine, or calcium channel blocker. So a few things for this primary treatment. If it's vasoreactive, you can continue with your calcium channel blockers, which are first line. Prostacyclines can be used like epoprostenol or iliprost. PDE5 inhibitors, phosphodiesterase 5 inhibitors like sildenafil, tadalafil. Endothelin receptor antagonists like bosentan. Oxygen therapy, especially if it's associated with COPD, which would be a classification 3. And long-term anticoagulation in some, if it's thromboembolic, which again is stage 4, or classification 4, I should say. Heart-lung transplant is definitive, of course. So next we'll go into the long topic of pulmonary embolism. So pulmonary embolism, an obstruction of the pulmonary blood flow due to a blood clot, usually a thromboembolism from a DVT. 70% arise from the deep vein in the legs. The majority of the rest of them are from the pelvic veins. So the popliteal and femoral are the most common. So the risk factors are SHE, which is Virchow's triad, SHE, stasis, hypercoagulability, and endothelial injury. So intimal damage, trauma, infection, and inflammation, stasis, such as immobilization, surgery, or prolonged sitting over 4 hours, and hypercoagulability, protein C or S deficiency, factor V Leiden mutation, antithrombin 3 deficiency, oral contraceptive use, malignancy, also pregnancy and smoking are risk factors. So don't forget that oral contraceptive, malignancy, pregnancy, and smoking. Clinical manifestations. Some of the symptoms of a PE are the classic triad, but not always there. Dyspnea, which is the most common, pleuritic chest pain upon breathing, and hemoptysis, which is classic but rare. They may have some cough as well. On physical exam, tachypnea is most common. Tachycardia may be a low-grade fever as well. Positive Homan sign, but that's not specific. And that's when you dorsiflex the ankle and palpate the calf, and there's tenderness there. So if there's a massive PE, it may present with syncope, hypotension, or PEA. So some ancillary tests in PE, although we'll go over the Wells criteria, etc., but chest radiographs are the most common initial tests to evaluate the chest pain in the first place, and the chest x-ray is often normal in PE. A normal chest x-ray, which is the most common finding, in the setting of hypoxia, however, is highly suspicious for PE, so it needs a further workup. Atelectasis is the most common abnormal finding. Classic but rare findings are the Westermarck's sign, which are avascular markings distal to the PE, and Hampton's hump, which are wedge-shaped infiltration due to infarction. So Westermarck's and Hampton's hump, those are commonly tested as well. So for EKG in a PE, it is very classic. You want to see that S1, Q3, T3 sign with that right heart dysfunction, but this is only in 5 to 20%. S1, Q3, T3, most specific sign for PE. So what that means is a wide, deep S wave in lead 1, both an isolated Q as well as a T wave inversion in lead 3. You also see some right ventricular strain as the heart tries to push against the lungs, right bundle branch block, or inferior Q waves. And again, nonspecific ST T wave changes and sinus tach are the most common. So sinus tachycardia is the most common sign, however the S1, Q3, T3 is the most specific sign. On ABG, you'll see initially a respiratory alkalosis secondary to the hypervention, the tachypnea that they're having, and you also see hypoxemia. Respiratory acidosis may occur with time or with a massive PE as well. The D-dimer, importantly to mention, is helpful only if negative and a low suspicion for a PE. It has a high sensitivity but a poor specificity. So it detects any clots, so there may be a clot anywhere with a D-dimer. So confirmatory tests for PE, the helical or spiral CT angiography, this is the best initial test to confirm the presence of a PE in most patients. It's 95% specific and highly sensitive as well. The VQ scan, used in patients when a CT cannot be performed, such as in pregnancy or increased creatinine due to the contrast. Pulmonary angiography, this is the gold standard, definitive, but it's usually not performed. Venous Doppler ultrasound of the lower extremities may be used if a VQ scan or a CT does not give a clear diagnosis. Serial ultrasounds may be performed to increase diagnostic specificity in patients with a negative PE. So how do we manage a PE? Hemodynamically stable versus unstable. We have to determine that, and then that will determine our management. So if they're hemodynamically stable with a PE, you want to just do anticoagulation as first line. And this is first line therapy in most patients, anticoagulation. So you want to do a heparin with a bridge to warfarin, or you could do a NOAC, a novel oral anticoagulant, such as dabigatran, rivaroxaban, apixaban, or edoxaban. Also, if they're having recurrent, you could do an IVC filter. So again, IVC filter, an anticoagulation for a hemodynamically stable patient. And the IVC filter is indicated in stable patients in 3 scenarios. If the anticoagulation is contraindicated, such as if they had a recent bleed or a bleeding disorder. If the anticoagulation is unsuccessful, if they're having recurrent PEs despite the anticoagulation, such as a warfarin is titrated to an INR of 2 to 3 and it's still not working, you can do an IVC filter. And also if right ventricular dysfunction is seen on echo. The next embolus, even if small, it could be fatal. So that's when you use the IVC filter if there's any of those 3 things. So that was for hemodynamically stable patients. Now for hemodynamically unstable patients. So this means a hypotensive patient with a systolic under 90, an acute right ventricular dysfunction. So you want to do thrombolysis if you can. This is hemodynamically unstable patients or severe PE with right-sided heart failure. It's contraindicated in a bleed, a CVA, recent intracranial bleed, or a bleeding disorder. Also, relative contraindications are uncontrolled hypertension, like over 185, over 110, importantly, surgery or trauma within the past 6 weeks. You could also do thrombectomy or embolectomy, which can be done if they're unstable or if they're having a massive PE if thrombolysis is contraindicated or ineffective. So now we'll go over PE probability and how you would, so I'm going to talk out kind of the algorithm of how you would follow through, and then we'll do the management of the pulmonary embolism as well. So for PE probability, you want to look at the Wells criteria, of course, which we'll go over. But for PE probability, if the PE is unlikely, then you want to do a D-dimer right away. And if they have a negative D-dimer, they can have a PE being excluded. If the D-dimer is positive, even though you thought the PE was unlikely, shift over to a helical CT scan. So once you get a positive D-dimer, you have to get a helical CT scan. And that shifts over to the side of PE likely. So again, PE likely, you go to helical CT. If the helical CT is normal, the PE is excluded. If the helical CT is indeterminate, you can actually go to a pulmonary angiography for definitive determination. Or if the helical CT is positive, then you want to treat for the PE. Then again, looking for that hemodynamic instability or stability to determine your treatment. So again, management of pulmonary embolism, hemodynamic stable or hemodynamically unstable. So if they're stable, you can do IV unfractionated heparin or sub-Q low molecular weight heparin. And you want to continue PO warfarin or a NOAC for at least 3 months. That's important, 3 months. So if they're hemodynamically stable and if anticoagulation is contraindicated, like we said, IVC filter. If they're hemodynamically unstable, you can do thrombolysis, or if thrombolysis is contraindicated, embolectomy. So next we'll go over the Wells criteria for PE. This is used to determine the clinical probability of them actually having a PE. 3 points are added for the following. So clinical signs and symptoms of a DVT, PE as the #1 diagnosis or equally likely. There's 1.5 points which are added for heart rate over 100, immobilization for at least 3 days or surgery in the previous 4 weeks, previous objectively diagnosed DVT or PE, and you get 1 point for hemoptysis or malignancy. And the interpretation, if they have a low probability, it's under 2 points. You might consider a D-dimer or see if you can use the PERC criteria, the pulmonary embolism rule-out criteria, which we'll talk about. So that's low probability, under 2 points. If they have moderate probability, 2 to 6 points on the Wells criteria, consider CTA or high sensitivity D-dimer. If they have high probability, over 6 points, do a CTA. So PERC criteria, the pulmonary embolism rule-out criteria, is used in patients with a low clinical probability of PE. The following 8 are part of the PERC criteria. So, in patients with a low risk who meet all 8 criteria, no further testing for PE is needed. In patients with a low risk but do not fulfill all the criteria, a D-dimer is indicated. So if they fulfill all 8 criteria, you don't need to work them up further. And these criteria are an age under 50 years old, heart rate under 100, hemoglobin saturation of 95 or greater, O2 sat, no hemoptysis, no estrogen, no prior DVT or PE, no unilateral leg swelling, and no surgery or trauma requiring hospitalization in the prior 4 weeks. So that's the PERC criteria. So now we'll go to the difference between unfractionated heparin and low molecular weight heparin. So for low molecular weight heparin, the mechanism is potentiates antithrombin 3. It works more on factor 10A than on thrombin itself, factor 2A. So low molecular weight can be done by an SQ injection. You have to do this with compliant low-risk patients, and they can be discharged home during the bridging therapy to warfarin. I remember they stay on this for 3 months. So the duration of action of the low molecular weight is 12 hours, and there's no need to monitor PTT, as it's weight-based and it's more predictable dosing. Protamine sulfate is the antidote, but it's not as effective as it is for unfractionated heparin. Low risk of HIT, heparin-induced thrombocytopenia, and contraindicated in renal failure because low molecular weight is excreted by the kidneys, and of course contraindicated in thrombocytopenia because we don't want to risk occurrence of HIT. And on the other side, for unfractionated heparin, same mechanism of action, a little bit more though, potentiates antithrombin 3 as well, also inhibits thrombin and other coagulation factors. So continuous IV drip requires hospitalization for bridging therapy. So unfractionated is in the hospital. Duration of action is 1 hour after the IV drip is discontinued, and you must monitor the PTT for 1.5 to 2.5 times the normal value. So the PTT is that intrinsic pathway, and that's where heparin works. And remember, the extrinsic pathway or the INR or PT pathway, all the same, are where warfarin works. So again, for unfractionated heparin, protamine sulfate is also the antidote. But for unfractionated heparin, heparin-induced thrombocytopenia is a much greater risk. So heparin-induced thrombocytopenia, to go through it a little bit, heparin acts as an hapten, stimulates the immune response when attached to platelet factor 4. This complex activates platelets, causing simultaneous thrombocytopenia and thrombosis. The management of heparin-induced thrombocytopenia is other anticoagulants, like agatroban, or rather argatroban, or bivalirudin. Do not use warfarin, as they may develop warfarin skin necrosis. So that was low molecular weight heparin versus unfractionated heparin. So now we'll go over PE prophylaxis. So the single most important step in managing a PE is prophylaxis. Prophylaxis is warranted post-operatively in patients undergoing surgery with prolonged immobilization, pregnant women, and a history of DVT or PE. So early ambulation is important with low-risk minor procedures in patients that are young. Elastic stockings or pneumatic compression devices or the Venodyne boots as well can be done. And low molecular weight heparin, patients undergoing orthopedic or neurosurgery or trauma procedures. So that's ambulation, stockings, pneumatic compression devices, and if it's real serious, you can use some heparin. Chest x-ray findings in a PE, again, normal chest x-ray is most common. Hampton's hump is that wedge-shaped infiltration, or infarct rather. And Western mark sign of those avascular markings distal to the area of the embolus. Again, the EKG findings that are classic are the S wave in lead 1, the Q wave in lead 3, and the inverted T wave in lead 3. That's the S1, Q1, T3. And the S1, Q1, T3 is due to the presence of cor pulmonale with a large PE. It's classic but not common. So the cor pulmonale is that right heart problem as well. So now to acute respiratory distress syndrome, or ARDS. ARDS is an acute, diffuse inflammatory form of lung injury and respiratory failure due to a variety of causes, associated with a high mortality rate due to acute hypoxemic respiratory and organ failure. The pathophys of ARDS is diffuse alveolar damage, and surfactant leads to increased permeability of the capillary alveolar barrier, leading to a non-cardiogenic pulmonary edema, shunting, and hypoxemia without hypercarbia. So you can't get in the oxygen in the first place, so there's no exchange, so there can't be hypercarbia. Risk factors. Most commonly develops in critically ill patients, especially gram-negative sepsis, which is most common, and other critically ill patients as well. So acute dyspnea and hypoxemia, multi-system organ failure, severe. And for diagnosis, we have to know the 3 different stages of hypoxemia. So severe hypoxemia is refractory to supplemental O2 also. So the stages are mild, moderate, and severe. For a mild hypoxemia, this is a PaO2 to FiO2 ratio of 200 to 300, and you want to use PEEP or CPAP over 5 centimeters of H2O for this. If it's moderate hypoxemia, this is 100 to 200 PaO2 to FiO2 ratio, and you can do a PEEP of over 5 centimeters H2O. And for severe, again, a PEEP over 5 centimeters of H2O, but this is 100 or less PaO2 to FiO2 ratio. So chest radiographs for ARDS will see bilateral diffuse pulmonary infiltrates. Bilateral diffuse pulmonary infiltrates, similar to CHF in ARDS, but ARDS classically spares the costophrenic angles. So it spares the costophrenic angles, but because it's actually in the alveoli itself as opposed to in the pleural space or somewhere else. So adult respiratory distress syndrome. Pulmonary capillary wedge pressure is important. So chest x-ray of ARDS and cardiogenic pulmonary edema looks the same. This will be a pulmonary capillary wedge pressure under 18 equals ARDS. A pulmonary capillary wedge pressure over 18 equals a cardiopulmonary edema. So that's important. So if you get the pulmonary capillary wedge pressure, you want to determine if it's ARDS or cardiogenic pulmonary edema. And they look a little bit different too on x-ray. And the management of ARDS is non-invasive or mechanical ventilation, plus treating the underlying cause. So CPAP with a full face mask, PEEP, and low tidal volume. Low tidal volume has been shown to decrease non-pulmonary organ failure and weaning. Positive end expiratory pressure, PEEP, improves hypoxemia by preventing alveolar collapse, which provides the ventilation-perfusion mismatch. It improves, rather, the ventilation-perfusion mismatch, as well as increases functional residual capacity, the volume of air remaining in the lungs at end expiration. So it's pushing air into it so it keeps them open. Sleep apnea. Sleep apnea is involuntary cessation of breathing during sleep. Complications include pulmonary hypertension and arrhythmias. Risk factors are obesity as the strongest risk factor of sleep apnea, also age, most common in the 6th and 7th decade in males. So there's 2 types. Central sleep apnea, which is reduced CNS respiratory drive leads to decreased respiratory effort, and obstructive sleep apnea. Physical airway obstruction, which may be due to an external airway compression, or a decreased pharyngeal muscle tone, or increased tonsil size, or even a deviated septum, importantly, for OSA. Clinical manifestations: snoring, unrestful sleep, which may lead to chronic daytime sleepiness, nocturnal choking as well. Physical exam: large neck circumference, crowded oropharynx, and microganthia. Diagnosis of sleep apnea is the in-laboratory polysomnography, which is the first-line diagnostic test, and 15 or more events per hour is obstructive or mixed apneas. Labs, you might see polycythemia due to the chronic hypoxemia, and the Epworth Sleepiness Scale, used to quantify the patient's perception of fatigue and sleep. So the management of sleep apnea is behavioral changes, including weight loss, abstaining from alcohol, and changes in sleep positioning. Also CPAP. This is the most important treatment, and it's the mainstay of treatment. CPAP is continuous positive airway pressure. Again, the mainstay of treatment in sleep apnea. Oral appliances can be tried if CPAP is unsuccessful or as an alternative. And for surgical correction, tracheostomy is considered the definitive treatment for OSA. And other interventions include, if they have a deviated septum, you can do a nasal septoplasty or a uvulopalato-pharyngoplasty. Normal breath sounds will be next. So normal breath sounds are bronchial, bronchovesicular, and vesicular. So bronchial are loud, high-pitched sounds heard over the trachea and the larynx, the manubrium, and the expiration is longer than the inspiration if you listen over the bronchial. Bronchovesicular is medium-pitched sounds heard over the primary bronchus and the posterior between the scapula. Expiration equals inspiration. And for vesicular, these are soft, gentle sounds over all the areas. And this is inspiration, which is louder than expiration. So abnormal breathing. So some notes about abnormal breathing. You have Cheyne-Stokes breathing, which is cyclical breathing in response to hypercapnia. Smooth increases in respiration and then gradual decrease in respiration with a period of apnea 15 to 60 seconds. This is due to a decreased brain blood flow, slowing of the impulses to the respiratory center as well. You also have Biot's breathing. Biot's breathing is irregular respirations which are quick and shallow, but they are equal depth with irregular periods of apnea, usually of equal depth again in comparison to Cheyne-Stokes breathing. It can be seen with damage to the medulla oblongata or opioid use, so that's Biot's. And then of course Kussmaul respirations. This is hyperpnea. Deep, rapid, continuous respirations as a result of metabolic acidosis. Deep respirations with a large tidal volume. So this is the body's attempt to compensate by blowing off the excess CO2. No expiratory pause, so no stopping between inhalation and exhalation. So such as DKA for Kussmaul's respirations. So next we'll go over two pediatric conditions, neonatal respiratory distress syndrome and meconium aspiration, to finish up the pulmonary section. So neonatal respiratory distress syndrome, this is atelectasis and pulmonary perfusion without ventilation due to insufficiency of surfactant production by an immature lung, primarily a disease of preterm infants. It's the most common single cause of death in the first month of life. Surfactant production begins between 24 to 28 weeks, so by 35 weeks enough surfactant is produced. So if they're younger than this, of course they're going to have difficulty with the lungs. Risk factors: Caucasians, males, multiple births, and maternal diabetes, also perinatal infections. Clinical manifestations of neonatal respiratory distress syndrome usually presents at birth or shortly after birth with respiratory distress, with tachypnea over 60 a minute, tachycardia, chest wall retractions, expiratory grunting, nasal flaring, and cyanosis. For diagnosis, we can see on a chest x-ray bilateral diffuse reticular, ground glass opacities plus air bronchograms, poor lung expansion, and doomed diaphragm. So that's that air bronchograms. For ABG is hypoxia, often unresponsive to oxygen supplementation, and they may have a slightly elevated or normal PCO2. So management is exogenous surfactant via the ET tube to open up the alveoli. You can do CPAP as well. Clinical course is 2 to 3 days with or without treatment, and 90% survival rate with treatment and normal returning of lung function in a month. So you want to prevent this actually with antenatal glucocorticoids given to mature the lungs, which is betamethasone, if their premature delivery is expected between 24 to 36 weeks, because the surfactant production only begins between 24 to 28 weeks. So again, prevention is those glucocorticoids for the maturation of the fetal lungs, and the treatment is that exogenous surfactant to the baby. So lastly will be meconium aspiration. This is an entrance of the meconium-containing amniotic fluid into the respiratory tract, leading to respiratory distress, hypoxia, and acidosis. Increased risk is in post-term infants and infants that are small for gestational age. It may occur with fetal distress and hypoxia. Clinical manifestations are signs of respiratory distress, and diagnosis is evidence of meconium staining amniotic fluid. Chest x-ray will see coarse, irregular infiltrates with lung hyperinflation. So you can kind of think the meconium kind of blocks all that air in, and then the lungs get hyperinflated. That's how I remember it. And may show pneumothorax as well. So management of meconium aspiration, prevention is the most important thing, is the most effective therapy, and the prevention is post-term delivery over 40 weeks via labor induction and prevention of fetal hypoxia. Supportive, maintain O2 and ventilation, empiric antibiotics as well, and correct the underlying electrolyte abnormalities. So that will conclude the pulmonary system of Pance Prep Pearls.